God has given me, blessed me with fantastic people around me. And it has been a beautiful journey throughout. And this journey, this part of my life, I'll call it as awesome, because the people around me are full of energy, full of wisdom, guidance, ethics, etiquettes, and everything else together. And so the lines which I spoke in Zainab's BTR, that's the line I want to start here, right? For our teachers, like Dr. Gobind Raigar sir, Dr. Vivek Jain sir, Praveen, and if I miss out Zainab's name, students are going to be angry with me. So Zainab and Dr. Sparsh, Dr. Dilip, and Rana ma'am, and all these, everybody who's a part of this family today, right? So the lines which I want to tell you is here that माना कि चुपचाप खड़े रहते हैं, पर जो लोग बड़े होते हैं वो बड़े होते हैं. हमारी महफिल सजती है उन लोगों से जिनके कदमों पर कई ताज पड़े रहते हैं. So that is to the people who are forming this team of Cerebellum Academy. And it is very important that we realize that that it is the courage that matters the most. And we all have fears, we all have fears. But if you go to the story of Mahabharata, there is one classical thing which is always memorized, and that is when the Danveer Karna was about to go and fight to Arjuna, everybody asked him that, will you be able to face this great warrior, Arjuna? You know what Karna said? He said, it is not that I have fear. I do have fear. And everybody has that fear. But what differentiates is that I have self-confidence that I will conquer my fear and I will face. And then he went to this battle to fight. And that's how we doctors do every day in our life. As Dr. Praveen wrote a day before the exam, that lots of exams will come, and this is one of them. We are writing exams every day, right? This is one such day. But we wanted to be here to talk to all of you about what happened. We have been classically saying, all of us who are a part of Cerebellum have been classically saying, जो आया है वही आएगा, जब तुमको ये समझ आएगा तब तुम्हारा नंबर आएगा. Whatever is common is commonly asked. If you answer the common things, you are commonly selected. That's what has been there. If you look at ortho, I have been telling that lower end radius, if there's a lesion, it is GCT till proved otherwise. It is the number one asked image in entrance exam. Joint. So that's, if you remember, that's how the question comes. You need to remember few nerves around the shoulder axillary, right? Around the shaft of humerus, radial nerve, around the hip sciatic nerve, around the knee common peroneal nerve. So fracture of fibula, CPN palsy, dorsiflexion lost. Night pain involving the zone of the median nerve is going to be carpal tunnel syndrome. So around the wrist is going to be carpal tunnel syndrome. These are things that agar koi tumse neend mein bhi puche, you have to know them. All right. Good thing for me is I recorded a video of 55 minutes. And Zainab, I don't think so I will have to do it again. I will just request the students to go with the same video for the next exam. And that is what I will like to say here, Dr. Gobind, Dr. Vivek, and all the teachers say. A good teacher is not the one who knows what to teach, but a good teacher is the one who knows what not to teach and not to overburden the students. And that's the principle of Cerebellum Academy. Give adequate, give complete, give comprehensive, but relatable and revisable. That is what we should know. All right. There was a question about the Shefford-Crook deformity and fibrous dysplasia. I'll give the credit to Zainab for it because she had shown in the class multiple times, and I will not take it away. And these were some of the things, Zainab, and I think whatever I missed, you can take over. So next on, Zainab wants to take over. You want to start, Zainab?
Yes, sir.
We have the great Praveen. He's waiting. He's called as the universe boss of cerebellum. And we have one of the most beautiful voices, Dr. Sparsh here, and a beautiful heart as well. We have the man who can balance himself on the bicycle, Dr. Dilip. We have the man with Shero Shairi, Dr. Shrikant Verma. Another accompanying Dr. Pooja, who's going to do the same thing. We have a phenomenal teacher of gynae obs, Dr. Rana, in the meeting, and we have the ophthalmologist, Dr. Gaurav Nagpal, also. So they will sequentially talk to you, but I think since Zainab has to leave early, we'll ask her to start. Is that okay, Sparsh sir, Praveen sir?
Absolutely, sir. With just a humble request that I see a lot of students making a remark in the comment section that Zainab ma'am, you're the godmother. Bhaiya, badi didi bolo aise. I don't think Zara is going to be compromising on that status with anybody whatsoever. And without wasting too much of her time, she understands that ma'am is having a very busy schedule and she has a lot of things planned for her. So we'll straight away pass on the baton to her, and subsequently we can then have a discussion. Ma'am, please.
Thank you.
Over to you. Thank you very much. Bye.
Vapur sir, thank you. Sir, so not just godmother, now students call me universal mother. I have accepted that status with a lot of love. So thank you so much, guys, for all of that. And hopefully the exam went well. It was just yesterday that we were so nervous about exam. We were all talking about around this time only we had a class for the exam strategy, and now we're here talking about how it all went. So overall, the feedback that we've been getting is a lot of repeat topics came. It was not a very tough exam, but it's never the questions which are tough. It's always the options which are tough, right? And in fact, an easier exam or a repeat topic exam is usually tougher to, score on as far as percentiles are concerned. So that is always one thing. So congratulations to all of you in just getting through it. First of all, give yourself a pat on the back that, you've gone through one of the biggest milestones of your lives successfully, intact. So whatever happened, now just get a good lunch today, get a good dinner today, relax, unwind. Do not see a lot of recalls. What happens is we go on this loop where we are constantly looking at a lot of recall videos and trying to find that one person who tells me the answer which I have marked. So don't do that. Just basically see it as an overview of how overall the exam went, how things went. I know it's easier said than done. There's a very normal instinct right now to, get back and find the answers to all of the 200 questions that you've marked. So try and relax and unwind in the process as well. Spend some time with your family, your friends. I think you deserve that for sure. And thank you so much for all the love. Really, really means a lot to us. So I'll start off with the questions from radiology then. I think that is what a lot of you have come here for. So I'll start off with the questions from radiology. I'll just share my screen and share the questions which I compiled. I would need the permission to share my screen by the host, and I'll do that. All right, I think that's fine now. Okay, is the screen visible? The first question actually is not, sir, is it all right now? Is it visible? Yeah. Okay. So the very first question which I have is actually not a radiology question. Yesterday I was just talking about this in the Ashirvad class which I had taken. So I just felt very nice. The very first message that the students have sent me was, ma'am, hormone sensitive lipase came, and it's a biochemistry topic, but then it really, that was the first thing that students thought of me for, because it's just yesterday we were talking about this. So that's the first thing that I've included. So I think that was really special that we just talked about it and it showed up. Apart from that, a lot of questions overlapping with orthopedics, as sir correctly said. I think all of these have been covered. If you just see that 1 hour orthopedic class on YouTube, I think all of these questions get covered. And it's not just this time. Since 2014, I can claim that if Apur sir is teaching in 1 hour, questions will come from that 1 hour, and that is what has always been happening. So fibrous dysplasia, there's a question on Shefford crook deformity, something looking like this. The students can just basically comment in the live chat or in the comment section. You can help us out with the exact recall here, but these are basically based on, right now we are not trying to find the exact options. Right now all we are trying to do is get the topics. We have to learn from the exam. The whole point behind this recall is not to find what came, but what do we take away from it and what is the learning for the future exams. So that is what we are trying to gauge here. So there's one question on FD and one question on GCT, which again goes on to basically show that if bone tumor is going to be asked, it's going to be GCT. Anything else can come, but GCT has to come. So this is one of the other questions which came. Apart from that, there's one X-ray, the exact image I'm yet to find, on consolidation versus effusion. They'd given option of upper lobe, middle lobe, lower lobe, and I think silhouette sign was what was being discussed. So we'll get an exact recall video also. But yeah, this is one question which came based on consolidation versus effusion. One question on ovarian hyperstimulation syndrome. I'm sure Raina ma'am will also discuss this. So this was on an IVF patient who presented with a very typical history, and bilateral bulky ovaries with large follicles were given. So this was ovarian hyperstimulation syndrome. One repeat question, direct repeat on putti kidney. This is something that you have to take away. Ki putti kidney pe question they have been asking for the past 3 exams. So you got this question one more time. So a very repeat heavy paper, I would say. And then one question which was ortho/radio again was on bipartite patella, and the funny thing which students said was aise likha hua raha tha. Was this the exact image, guys, that is shown? Students said that is written in the question itself that this is the answer. So if that was the case, then that's good, right? This was again something which we discussed yesterday, that sometimes you will question ki yaar, is this too good to be true? And I talked to a few students and they said that ma'am likha hua tha, but it looked like a patellar fracture. So we thought maybe it's a trick that the examiner is playing, and we marked patellar fracture. So there the learning goes on is basically don't think too much, right? When it is given in the question, it is what it is, right? So this is definitely bipartite patella. In fact, it's a mimic of patellar fracture. What you have to look at here in this image is there are sclerotic margins. Okay, so this was one of those questions wherein you don't have to overthink too much. Then EDH versus SDH, also a classical conundrum which always figures in the paper. So there was again an image, but this time the image was not very obvious. Usually they give a very, very obvious image in EDH. I think this was an image which was similar to this, wherein it does look like EDH. So this is something that, if I was also writing the paper, I would have a problem with as a radiologist, because this is not a typical EDH. This is not a typical SDH. But when you look at the history, here the history was given that there is an alcoholic patient who had a history of fall. So when you read that, in that case, it goes in the favor of SDH, all right? And that is what it is. It is a subdural hematoma. So some things, you have to integrate. So the learning here is you have to integrate, and the history plays a very, very important role where the images are confusing. So clinically also it will happen that the image will not always tell you the diagnosis, so you do rely on the history. Okay, so elderly patient or basically alcoholic patient, if few of you are saying it was alcoholic, few of you are saying it was elderly, so basically both of them, either of them was the history, it does favor a diagnosis of SDH. Apart from that, apart from that, you had a question on angstpon, again a classical repeat, right? A classical repeat question of ankylosing spondylitis diagnosis, I think, was asked. A question tha on radio sensitivity. So radio sensitivity about, I think this was a direct repeat question wherein they talked about acute radiation exposure and what is more sensitive. So ye bhi ek direct repeat tha about radio sensitivity. Uske alawa, a few other allied questions. One was on fibular neck fracture that Apur sir discussed about CPN palsy and impaired dorsiflexion. One question on Pancoast tumor, wherein they gave you some history of sympathetic plexus getting involved, right? So that was Pancoast tumor. There was a question saying temporal bleed on a CT and infection was asked. So HSV encephalitis, remember, is a hemorrhagic encephalitis, right? So HSV would be the answer there. For periventricular calcification, we remember V for CMV, right? This we have discussed so many times. So CMV is periventricular calcification. Same question on CMV one more time, right? So again, you will have questions on same topics. Do not think that answer would be different just because it's getting repeated. That's also one thing that you have to, be aware of. Auli nucleus for CMV was asked. So 2 questions actually from CMV. This question I did not really get a good recall on, where there was a frontal sinus swelling, whether it was a mucocele or, sometimes they do ask Pott's puffy tumor a lot. So I'm not sure on this one. So I would need help with recalling this question, wherein there was a frontal sinus swelling which was impaired. And then there was Krupp, classical image of Krupp, wherein you had steeple sign. So this was asked, and Kiffel hematoma calcified. This was a good question that they've given. So there was a 2-month baby with fall, and they've given this X-ray here, which is showing a calcified Kiffel hematoma. So I think these were the questions. So overall, I think every specialist thinks their subject is very important. So I also feel that radiology is very important, and integrated, I think around 18 questions could be solved if our radio is strong, which I hope it is. So this was there. Apart from that, okay, so pseudo tumor of orbit was one of the options. Right. So this we need to sort out. This question I would need further help with, which is frontal sinus mucocele, whether it was a mucocele or it was an orbital swelling. I think this we have to figure out. Apart from that, I think the other questions are all sorted, but what's the takeaway? So this is a session wherein we are not trying to give you the exact recall. What we are trying to do here is tell you what do we do next? How do we go ahead from this? So I think overall what the learning would be is that it was not a very out of the blue paper, where we need to re-evaluate our strategy and change something drastically. No, it has never been the case. No matter what exam comes, it has never been the case that we need to take drastic measures and change our strategy completely. So I would just tell you one thing in the end, before I take anybody else's time. I just want to tell you that focus on the basics, right? Pareto's principle, 80% stuff comes from 20% topics. That is our motto with Cerebellum. That is what we've been saying all of these days, and this paper just proves that. All right, so just stick to basics, guys. Don't worry at all now. Whatever has happened, again, do not really judge yourself too much today. Just take it easy, take a break. You have gone through one very big milestone in your life, and relax, unwind. And now what you have to do is, we will take one day off tomorrow. We will just sit with an open mind, and we'll see how do we go ahead, right? What do we do next? How do we rectify where we went wrong? And that is the takeaway from this, that we will focus on the basics. We will do our basics right, our previous year topics right. And first, we will be happy with whatever has happened, with the effort that we have put in. So thank you so much. And I think Sparsh sir, you can come in if.
Thank you, Zainab. If you stop share, I'll request somebody to talk.
Yes.
Sir, I'll just join in with the questions that I have. Unfortunately, I don't have too many images with me as of now. I just have some, key statements which people can just confirm in the chat that were these.
Sir,
Hanji.
all will like to thank you and Praveen sir for getting all the faculties in such a short notice. The students should understand this thing, that there are about 7 to 8 faculties just waiting eagerly to help everybody. That is on the principle of the lines coined by Goga Bhai and Vivek sir for the students by the teachers. And thank you, Zainab. Over to you, Sparsh sir.
Hanji. So, few questions I can just recall was that there was a question which talked about the presence of, an acute leukemia-like presentation wherein the patient was having the presence of features suggestive of DIC. And then they asked you about the kind of subtype of AML that is associated with features of DIC. So most of you know that fact, translocation 1517, you associate with AML M3, right? That was easy one, I think. And another classical one that we have talked about in the ORR sessions as well, which most of you have seen as an image in the 20th book as well, beautifully compiled by Zainab ma'am, was that of a patient who was having the typical jaw mask, and that classical history wherein he is having the presence of translocation 814. So that was Burkitt's, right? Then the third question, as they made a mention of the fact, was patients who are having the presence of spherical RBCs, and I presume that we have talked about that particular fact so many times earlier, that they would typically give you all the options associated with spherocytosis, and they'll ask you ki sabse common kaun sa hoga. So obviously that is going to be remembered and recalled by you. I mean, do correct me if there is anything I'm missing out on. Autoimmune hemolytic anemia is the commonest cause, unless and until they made a mention of positive family history, or one member from the previous generation being affected always. So that would have been something like a hereditary spherocytosis like condition, right? Another one, which was an example of an occupational disorder. I think both me and Vivek Jain sir covered it very beautifully when we talk about pneumoconiosis. And this was a question taken from the Q Bank of, in fact, the National Board, wherein this guy happens to be a worker in a construction factory, right? Wo X-ray diya hua tha, wherein they were having the presence of the eggshell calcification kind of a picture. So construction worker, the commonest pneumoconiosis that we talk about happens to be silicosis. We then had a question wherein there was a peripheral smear which was having the presence of this smudge cell, and as we understand, smudge cell, because of that Vimentin defect that we all know is associated with the commonest leukemia in adults, that would be CLL. Then a question which you need to confirm was the fact that if the patients are going to be having, you see, construction worker can be having silicosis as well as asbestosis, but if you can perhaps let me know what was the additional thing which was mentioned. Then we can talk about a patient who was having the presence of some kind of a lung cancer. It made a mention of the fact that there were hyperchromatic cells which are present, and they asked you the subtype of cancer. So hypercalcemia, so we understand, is associated with squamous cell carcinoma. We have talked about it. Adenocarcinoma normally associated with migratory thrombophlebitis. I hope most of you do remember that particular fact, right? Then we did get a question in the exam pertaining to the accessory topics that we made a mention of. Like in Hodgkin's, we talked about the Reed-Sternberg cell having an aula appearance, but the question this time was on aula inclusions, typically associated with the CMV infection. Then we did make a mention of something like the Warthin-Finkelday cell, and I always keep on integrating with you the fact that the patients are going to be having a history of not being immunized. Then there is going to be a presence of something like a reddish colored spot opposite the second molar tooth. So Koplik spot was given, I presume. They asked you the diagnosis. So that was measles, pretty much clear. Then the question also that we talked about in the very introductory part of a discussion of hematology, wherein we talk about that hematopoietic stem cell differentiating into the myeloid and the lymphoid stem cell. So that was a question asking you about the interleukin 11, Oprelvecin, you remember, I hope. That is a platelet stimulating drug. So I'm not going into pharmacology per se, but just having a discussion about the fact that these were the things that we did talk about over there. There was one question which was talking about a patient having a history of chronic alcohol intake and some nutrient deficiency resulting in anemia. I'm not, just confirm it to me whether it was a nutrient deficiency or whether it was a vitamin deficiency. Chronic alcoholic, very important cause of development of macrocytic anemia, because these individuals are at high risk for development of folic acid deficiency. So keywords that we talk about, okay. And some more questions coming our way. A question on Horner syndrome. Unfortunately, I didn't get it with the limited time that we had for the purpose of recall, but if you can just let me know. Okay, filgrastim was also there. Same paper had Oprelvecin also and filgrastim also. Very unusual, actually, I would say. But okay, they asked you about a vitamin only. So these were about the 12 or 13 odd questions that I was able to recall. Time permitting, as I get more of them, I might as well share them with you. We are going to be having a proper recall with you as well. But I presume, all in all, having a look at the questions, everybody who had attended the ORR sessions and did pay attention to the fact wherein we were not only memorizing the facts, we did talk about the clinical histories, which are likely to be the norm now, and you are having the pattern already being decided for the next step 1, step 2 as well. This is going to be the norm for future as well. So I do hope that most of you did really well for that. Right. So all the very best. And I'll just pass on the baton to, okay, membranous and association. Okay, that was another question. Good. So membranous glomerulopathy associated with hepatitis B and schistosomiasis is what we had made a mention of the fact earlier as well. Thank you for that recall, Dr. Tiki Mukherjee, Kubalwachin. Thrombocytopenia. Okay. Okay, thrombocytopenia and Oprelvecin wala concept. Okay, got it. Did we get a question on von Willebrand disease as well? If you can just confirm, perhaps the last thing I can have a discussion about. Von Willebrand disease. Okay, bleeding in the joint. So there was hemarthrosis as a child, and Okay, same question. You had option of filgrastim and oprelvecin. Agreed. Got it. Sir, Praveen sir, would you like to take over? Vivek sir?
Yeah, now Praveen sir will be taking over. And before Praveen sir starts with his discussion, I just want to tell you, sir has taken a beautiful session on Cerebellum YouTube. That was a wonderful session by Dr. Praveen Tripathi. And for your exam, whichever you come next or this exam, I sincerely have got lots of messages that almost everything came from that session. So Praveen sir, before you discuss the questions, I will like you to talk. When you were taking that session, what was the content that you were thinking about while making that session? Because students should understand that mindset, so they will understand how to attempt the paper. And following Praveen sir, you will pass the baton to Vivek sir, who's already joined. Right? Thank you very much.
Okay, unmute. Yeah, am I audible and visible?
Fantastic.
Great. All right. Good evening, students. Thank you, Pur sir. So to answer sir's question, whatever short sessions all of us took, all the faculties of Cerebellum took, the whole idea was that, the questions that are asked repeatedly, we should not allow any of them to get missed. And this time the paper was quite, heavy on the repeat questions. So that is why almost all the questions were coming from those short sessions that we took. Anyways, so let us start with the discussion of the questions that were asked from the subject of psychiatry. Can I share my screen? I think I can. Yes, okay. All right. There we go. So, is my screen visible? All right. Okay, so this was actually a good question that was asked in this exam. I'm actually happy that they asked this question, although it's a repeat question, but in a different way this question was asked. So, Hanji, thank you. Thanks everybody. Thank you for the kind remarks that you're making here. All right, a patient with schizophrenia who did not respond to haloperidol and thioridazine was started on drug A. And after starting the drug A, the patient's psychotic symptoms improved. However, he developed cyalorrhea, dyslipidemia, and weight gain. Which drug is likely to be drug A? So first of all, was this the question stem in the examination? Is it the correct statement? Correct question stem? Fair enough. So I think it's a simple question. What is the diagnosis? The diagnosis is, of course, treatment-resistant schizophrenia. We know that if a patient does not respond to two different antipsychotics, we call it TRS. So here the patient has not responded to olanzapine नहीं था, ziprasidone था. अच्छा ठीक है, तो ziprasidone कर देते हैं इसको. Any other mistake in the question, students? Aripiprazole was in the option. Okay, fair enough. Aripiprazole. What else? Stem was correct, options not. Okay. Ziprasidone. Weight gain nahi tha. Okay, there was no weight gain. So what was there apart from cyalorrhea and dyslipidemia? Yes, medicine hitters. Can you guys tell me what was in the question stem apart from cyalorrhea and dyslipidemia? Was anything else mentioned? Weight gain nahi tha. Weight gain was not there. Tha. Okay, some of them are saying tha. Okay, see, it doesn't matter. See, weight gain is not the clinching evidence here. The clinching evidence is cyalorrhea, as some of you might have understood by now. Let me write weight gain for now. So, patient has not responded to two different antipsychotics. Our diagnosis is treatment-resistant schizophrenia, and we are being asked what is drug A. So even if we forget the second part of the stem, just on the basis of the first line, we can kind of think that the drug A is clozapine, because clozapine is the drug of choice for treatment-resistant schizophrenia. Now, there's this another very commonly asked MCQ. What are the common side effects of clozapine? So the commonest side effect is sedation followed by cyalorrhea, excessive sedation. So by telling that the patient's psychotic symptom improved and also saying that the patient developed cyalorrhea, our answer of clozapine becomes even more sure. And we also know that clozapine is the drug which can cause the maximum weight gain. out of all the antipsychotics, maximum weight gain is associated with clozapine, and of course, metabolic side effects like dyslipidemia and others. So hyperglycemia was in the question. ठीक है. Okay, fair enough. तो weight gain and hyperglycemia भी कर देते हैं. Right. So all of these are the metabolic side effects, and all of them are most commonly seen with clozapine. So our answer becomes option B, clozapine. I'm sure most of you would have gotten this question correct. Clozapine. ठीक है. हाँ, patient was elderly. See, even if the patient was elderly, doesn't matter. When we have the diagnosis of TRS, the drug of choice becomes clozapine. Right. Going to the question number 2. All right. So some students have told me that the question said a middle-aged female presented with complaints of repeated episodes, and some said a medical student presented. So medical student should not be a middle-aged female, although you never know. What was in the question? Was it a middle-aged female or a medical student? Yes, sir. क्या मतलब yes for what? Middle-aged female or medical student? I did not attend this question only. Okay, ji. Middle-aged female or medical student, guys? No middle-aged. Medical student. ठीक है. So medical student. So by the time the medical student stops being a student, she will anyways become a middle-aged person. Anyways, a medical student, I'm sorry, a medical student presented with complaints of repeated episodes of around 30 minutes. Okay, so these two terms are important. First of all, we have got a repeated episode. So it's an episode, guys, episode. And secondly, medical student. अरे यार ठीक है, मेडिकल स्टूडेंट थी या मिडिल-एज फीमेल थी, जो भी थी, डज नॉट रियली चेंज द आंसर. चलो, और मिडिल-एज फीमेल. ठीक है. So important is repeated episodes, then 30-minute duration, and you guys are saying fear of impending heart attack. Okay. So it's a very simple question, but for some reason some of you got it wrong. Episodic illness characterized by anxiety symptoms, somatic symptoms of anxiety, and fear of impending heart attack. And the duration is also typically 30 minutes, right? This is a classical panic attack question. These are panic attacks, and the patient has been having these attacks 2 to 3 times per month in the last 6 months. So if somebody has repeated panic attacks, then the answer becomes, of course, panic disorder. And the investigation did not reveal any obvious abnormality. Okay, I have this question. Did the question stem say that the investigations included ECG and echo? Did they mention what investigations were done? Did they say that ECG and echo were done 5 to 6 times per month? Okay. Anyways, did they say ECG and echo were done? No, sir. Okay. So anyways, we are having a patient who's having repeated panic attacks. Symptoms are classical of panic attack, 2 to 3 episodes or 5 to 6 episodes per month, whatever it is. The answer becomes panic disorder. So some of you are saying that you mark GAD as the answer, generalized anxiety disorder. See, generalized anxiety disorder is not classically an episodic illness. Generalized means that the symptoms are generally there, right? So although generalized anxiety disorder would also present with anxiety symptoms, but such classical episodes, which are lasting for around 30 minutes, and typically this line, fear of an impending doom or fear of impending heart attack, it goes significantly towards panic disorder. नहीं, see देखो 6 months के लिए GAD नहीं बना सकते आप diagnosis. Please never ever make the diagnosis on the basis of duration of the symptoms, right? Neither you have to make a diagnosis on the basis of gender. Both panic disorder as well as GAD are more common in females. Okay? So it does not matter whether the duration of symptom is 6 months or 3 months or 1 year. We'll have to go with the symptoms, and the better answer would be panic disorder. Chale, the answer is panic disorder. There is no confusion about it. Let's go to the next question. Impending to death. हाँ, ये exactly. You know, this whole line, fear of impending death or fear of impending heart attack. This is classically seen in panic disorder. Did it say fear of impending heart attack or fear of impending death? Did it say fear of impending death or fear of impending heart attack? ये बता दीजिए मुझे, वो did it say fear of impending death or fear of impending heart attack? Impending heart attack. Fair enough. ठीक है. Let's go to the next question. Now this is slightly tricky, right? And please let me know if the question stem is correct or not. A husband and wife, a couple presented to the OPD with complaints of premature ejaculation, which is in turn leading to frequent conflicts between the husband and wife. Which of the following non-pharmacological technique is most appropriate for the treatment? Is the question stem correct? Is the question stem correct? हाँ, जल्दी कर रहा हूँ. Is the question stem correct? ठीक है. So if this is the question where they have clearly mentioned about premature ejaculation, in that case the better answer becomes the squeeze technique. So see, squeeze technique as well as sensate focus technique both can be used. Sensate focus technique can be used for all the sexual disorders, but squeeze technique is specifically used in the premature ejaculation. So the better answer would become squeeze technique, right? So the answer is option A, squeeze technique. I think fairly simple question, a repeat question. ठीक है, let's go to the next question. तो same question कैसा आ गया? Anyways, the next question was something like this, right? They talked about a patient who is having complaints of confusion, ataxia, and 6 nerve palsy. Did they say that the patient had alcohol use history? Did they say that the patient had alcohol use history? They said that the patient had alcohol use history. Delirium tremens was one of the option. अच्छा. Alcohol use की history थी क्या? Can somebody tell me what was exactly in the question stem? So did they tell the age of the patient? Alcoholic patient, okay. Alcohol history was there. Alcoholic patient. ठीक है. What was the fourth option, guys? Nystagmus भी था. ठीक है. 6 nerve palsy के साथ nystagmus हो गया होगा. What was the fourth option? Alcohol addict, no option. What was the fourth option? 40-year-old. 40-year-old patient with chronic Othello syndrome. Okay, so I think there were two questions from this topic. One was, I believe, biochem question. In biochem question also they had given a similar history, but they had asked D current board. ठीक है. There was another question with the similar history, but there they had asked which vitamin is deficient, and I believe they had also given the name of the enzymes. So ठीक है. Anyways, this is a very simple question. We have got confusion here, we have got ataxia here, we have got 6 nerve palsy here. Of course, the answer is Wernicke's encephalopathy. There is no doubt about it. अच्छा, आप में से कुछ लोग बोल रहे हैं कि लुई बॉडी डिमेंशिया पे भी कोई क्वेश्चन था. Was there a question on Lewy body dementia? Answer remains Wernicke's. There is no problem. So can somebody tell me what was the question on? Okay. B1 and transcretalis. Fair enough. Okay. So a similar question in that the question was which vitamin is deficient, and the answer was thiamine. So yeah, it's a different question. So what was the question on Parkinson's, Lewy body? What was it? Can somebody tell me? Was it on Parkinson's disease? Lewy body dementia. अच्छा तो कोई क्वेश्चन बता दो भाई, क्या क्वेश्चन था? 7 Lewy body, a female of 73 years. Can somebody write the proper question? Progressive weakness. Acha, so then it becomes a neurology question. Progressive weakness with histology showing Lewy bodies. Acha. So that Dilip sir will cover. ठीक है. गोगा सर को क्या होगा? गोगा सर क्रिकेट खेल रहे हैं. ठीक है. All right, so these were the questions. Prion disease was answered in Lewy body. ठीक है. So I think that was a neurology question, not psychiatric question. 70-year-old female visual hallucination dementia. चलिए ठीक है, इसको मैं चेक कर लेता हूँ. I'll check before, I don't want to spend too much of time on this particular thing. ठीक है. So the last question I'll find out, and I'll when I release the video on the questions, I'll include that question in that particular video. All right, thanks a lot, guys. I hope you got you did the exam well, and I'm sure you'll get a great result. Over to, I believe, Vivek sir.
Thank you, Dr. Praveen. Thank you, Dr. Praveen. And I believe आपका ये जो पीछे फ्रेम है सरस्वती माँ, that's the favorite frame for everybody, and we all need the blessings.
Right, sir.
Next man, I just have few things which I have written for him. You leave magical marks and pieces of you everywhere you go. Don't dull the spark that makes you shine. The world needs it to be brighter.
सर ये मेरे लिए है, मेरे बात किसी और के लिए?
डॉक्टर विवेक जैन सर के लिए.
अच्छा, मैंने कहती तारीफ समझी करते नहीं कभी.
तुम्हारे लिए तो यूनिवर्स बहुत है. This is for and I think Praveen and Dr. Sparsh, you both will absolutely agree with my words for Vivek Jain.
100%, sir. 100%. As I recently mentioned somewhere that Vivek sir is not goat for only students, but even for the teachers like us. So we all look up to Vivek sir and still learn a lot from him.
And when we have backbones like him and Goga sir, you can always take the sprint, the marathon, whatever you wish to.
100%, sir. 100%.
सर उसका तो रीजन है ही ना. फिर आप गोविंद के शरण में आ रहे हो और पूरे विवेक से काम ले रहे हो, तो ऐसा कैसे हो सकता है कि सिलेक्शन ना हो या लाइफ में आपको कोई कष्ट आए?
और इतना प्रवीण स्पर्श हो तो तुम अपूर्व तो बनी.
बच्चे कहेंगे सबके सब नार्सिसिस्ट है, अपने नामों के बनाते रहते हैं बात के लिए.
Bye Tada, thank you. Bye sir, over to you, and Dr. Priyanka will take over from you. Thank you very much, sir.
Thank you so much, Dr. Apur sir, Dr. Praveen sir, Dr. Sparsh sir. Sir, please allow me to share the screen.
Right, sir. I've stopped my screen sharing. Okay.
Okay, friends, pranam dosto. NEET PG paper was quite easy for PSM today. What I've got till now is 20 questions, and there is no excuse if you have not got 18 or 19 correct minimum. I'm saying this is because paper was one of the easiest I've seen in recent times. Yes, few tricky choices will come later, confusions will be there, but let us go quickly through these 20 questions. I've been allotted 15 minutes for this session. Let's start with first question. There is a question on diet. 97.5%. If it is able to cover the nutritional requirement, this is known as RDA, recommended dietary allowance. I'll not go into the choices because most of the questions were fairly direct, right, friends? So 95% of population, 97.5, and I think you can mark also where this number 97.5% has been arrived from. Yes, this is mean plus 2 standard deviations. That means only for 2.5% of the population, that recommended RDA for a given nutrient will turn out to be inadequate. So if they say vitamin A requirement is, let us say 1000 microgram per day, then that 1000 should be sufficient for 97.5% of the population. only 2.5% it will turn out to be inadequate, which is more than sufficient. Okay, we move to next question. Next question was, which vaccine you will give to a 10-year-old child? Anti-rabies vaccine was given in the choice, but we are looking at national immunization schedule. Why will we give anti-rabies vaccine if it is not required? So which vaccine you should give to a 10-year-old child? Yes, you are right. It is TD vaccine. All of us know, we have been stressing in all our sessions from medicine, pediatrics, and PSM also, that earlier it was tetanus toxoid, but now at 10 years, 16 years, and in pregnancy, tetanus toxoid in India has been replaced with TD, tetanus diphtheria. D is small because it is in smaller quantity, right? Okay, let's move forward. Third question I got from you students only was, patient is having sputum smear negative, but his X-ray is positive. Under National TB Elimination Program, what should be the next step of management? So friends, sputum smear negative, if it comes, you are having a suspicion that the patient may be having pulmonary tuberculosis, best is to repeat the sputum smear testing. But if it is not an option available, then we have a better test available, X-ray is positive, CB-NAT test. See, what is the simple rule in National TB Elimination Program of India diagnosis? Go to sputum smear first, but if you cannot go to some reason that it is turning out to be negative, patient is extrapulmonary, then the only option, best option available with you is CB-NAT test, right? So I hope 100% of you have got this answer correct in the question, right? Okay, I'm sure. Okay, friends, then fourth question I got was, here in this fourth question, this was a surprise that many students got confused. Question was, a 30-week pregnant female, she is not eating papaya and other fruits due to customs or wrong beliefs. Who will educate her during home visits? So they are saying nutritional education in home visits. Choices I got from the students were Asha, Anganwadi worker, and healthcare worker female. Now friends, please be careful. Not every question has Asha as the right answer. See, this was a very tricky thing. They are saying home visits. They are talking of not the postnatal period. Please be careful. Asha mostly makes visits in the postnatal period. Multi-purpose worker, that is healthcare worker, also make visits in the postnatal period. So Asha and healthcare worker is not correct. Here answer is Anganwadi worker. This is actually correct due to one more clue you should have realized. ICDS, Anganwadi system. We have nutritional supplementation of a pregnant female at the Anganwadi. So if the Anganwadi worker is giving the nutritional supplementation, then definitely that has to be, she is the worker who has to take care of the nutritional education and the aspect of the female, right? So Anganwadi worker, until less language, if something was different, do let me know, right? Okay. Let's move forward. Next question was, okay, again, students have created different versions of this question. They say female presented with vaginal discharge. Some said she presented with cervical discharge or erosion. Now, friends, you have to tell me which was the correct statement given in the question. Was it only vaginal discharge, or was it vaginal discharge plus cervical discharge or erosion? Friends, I'm waiting for your answer. There is a lag of around 10 seconds in each live stream. So just I'm giving it. Okay, students are saying both were there. Okay, friends, let me tell you, in case single, either one of them were there, if vaginal discharge is there, which STD color coded kit will go? Kit number 2, that is green. If only cervical discharge is there, then you will go for kit number 1. Cervicitis is there, right? That is gray. But if both were there, vaginal discharge, and there is mention of that there was cervical discharge or erosion. See, vagina to cervix, ascending infection, you're talking of PID. So this will be kit number 6, that is yellow. So depending on the question, the choice will be there. Yes, language may be there, that wife of a truck driver was there, anything, but pick up the keywords. Only vaginal discharge, green. Only cervicitis, gray. Combination of both favors in the, or go in the favor of PID, that is kit number 6. Let's move further. Question number 6. I think this was the easiest question. Diarrhea, dermatitis, dementia. This question has been coming since last 10 years now. Even niacin has got angry, but it will keep on coming. So we are talking of Pellagra, 4 Ds, diarrhea, dermatitis, dementia, death. So definitely, friends, this was easy. Let's go further. Okay, examiner was giving 19 easy questions. So he had to make sure that one question remains difficult because 95% is the confidence limit, right? So he asked you Colombo plan. Friends, in public health, Colombo plan is one of the oldest plans, 1950, 70-year-old plan. Therefore, you will not find it in many of the books, most of the books. No teacher even teaches this because this is quite old. But this, I don't know the exact question because everyone is just asking Colombo plan. Some are saying it was for cancer. I'll tell you what exactly Colombo plan included. It included economic development on a cooperative basis. Then you can tell me what was asked in the question. Here it was focusing on industrial development plus agricultural development mainly. Also, there was a small component of health promotion. Under Colombo plan, AIIMS Delhi was established with the help of New Zealand, and Canada helped in establishment of CTU, cobalt therapy units. This may be related to cancer if that was mentioned in the question. So cobalt therapy units in medical colleges were introduced through Colombo plan. So friends, depending on the choices given, you will have to mark the answer. So it was economic development. Main focus was on industrial agricultural development. Some focus was on health promotion. 2 major introductions in medical colleges. One was AIIMS Delhi, established with the help of New Zealand, and Canada helped us in establishing cobalt therapy units in the medical colleges. So depends on the choices. I personally feel from a PSM point of view, if I am the teacher, I will put cobalt therapy unit in the choices. So this is a 70-year-old question. So definitely examiner was still under the influence of alcohol when this question was asked. Let's move further. This was the only difficult question, friends. Other 19 questions were quite easy. Then again, one of the old questions which we have been teaching since so many times. Raw egg leads to deficiency of. I am sure 100% of you have got this answer correct. You have read this in biochemistry also. So integrate PSM biochemistry here. What is the answer, friends? Waiting for your answer. Okay, I'm sure all of you have marked correctly. This is biotin deficiency. I'm sure all of you know the reason. Raw egg contains avidin. And what avidin does? It impairs absorption of biotin by tightly binding to it. So if you cook the egg, then this inhibitory activity of avidin is released and biotin is absorbed in the body. So raw egg is not good because it leads to biotin deficiency. So everyone is correct, I feel. Next question I got. This was only given by one student. So kindly confirm if this question was there or not. There was a clean cut wound in a male with TT received 10 years ago. What should be the management of this patient? Friends, if it is a clean cut wound and he has received, let us say, vaccine 5 to 10 years ago or more than 10 years ago, this is category B, category C. In both, you have to give only tetanus toxoid 1 dose. So I'm sure all of you marked this correctly. Yes. Okay. Good to see everyone is marking correctly. Yes. Great, friends. I'm happy. Wow. Lovely. Okay. Next question. I think this was fairly easy question. They asked about Koplik spot. rash on face. So friends, as I have discussed in the topic of measles in my book also and videos also, that retroauricular origin of rash, which comes down to face and then goes downwards. Coplic spots is pathognomic. So disease we are talking of is definitely measles. Right? Okay, let us move forward. So this was easy question. Another easy question students mentioned, there was some question on aniline dye occupational health workers. So Dr. Spurser must have taught you this in pathology. This was a repeat question from last year also. Transitional cell carcinoma, bladder carcinoma. Wherever nitrogen aniline dyes are there, bladder carcinoma, most common subtype is transitional cell carcinoma, TCC. Okay, friends, we move further. There was a question on cement industry workers. And they made a mention of X-ray changes. Now, friends, as we have discussed so many times in my sessions, live sessions also, cement industry workers, most common is silicosis. Second most common is asbestosis. Both are C. Single answer, silicosis. Silicosis, what you will find will be, yes, just like you get in sometimes confusion with tuberculosis. Eggshell calcification, I think Dr. Spurser also mentioned briefly a short while ago. Then you will get snowstorm chest X-ray, although that is seen in multiple conditions, depending on which type, and asbestosis. If it is there, mesothelioma. So see, it depends. Many students were saying that mesothelioma was mentioned in the question. If mesothelioma is mentioned in the question, I will only and only mark asbestosis. Don't have to think about anything else. But if mesothelioma has not been mentioned in the question, go for silicosis as the first choice, friends. Okay, everyone is saying mesothelioma was mentioned. Dr. Shalini Divakar has confirmed. Dr. Gayatri Pawar is saying. Okay, so then we will go for asbestosis if mesothelioma was mentioned, because that is specific. Okay, then there was a question, white fingers. You may read it in medicine, mentioned in Park textbook, my book also, very explicitly. White fingers we are talking of is, yes, due to vibrations. So which group of medical professionals white fingers may develop? It is a medicine related question. It is dentists who are using drilling instruments. So drilling instruments, orthopedicians, Dr. Apur sir will also tell you this, right? So dentists, orthopedicians are likely to get white fingers. Otherwise, people who use drilling machines for long times, generally 110 to 500 hertz frequency. This leads to white fingers. It is more or less related to Raynaud's phenomena that you read in medicine and surgery also, friends. Okay, then we move to next question. Next question was on BOA. Some students mentioned treatment of neuroletharism was asked. So I'll mention both. BOA is beta-oxalyl aminoalanine. So we are talking of disease letharism. Lethyrus sativus, Khesri dal. And then treatment of neuroletharism. Yeah, treatment of letharism. Neuro they mentioned because it is the form more commonly seen in human beings. This includes vitamin C prophylaxis, ban the crop. Friends, this is a repeated question from the last time. Also, it includes health education, that ideally Khesri dal should not be consumed. If it has to be consumed, it should be less than 30% of the total dal consumption. Also, we can use parboiling or steeping method. They will help in removal of toxin. We also use genetic approach nowadays to solve this issue. Socioeconomic development is another way how we can. Okay. Dr. Anuj is saying there were two different questions on this. Okay, friends. So BOA is for letharism, the toxin, and this is the treatment of toxin. I hope I have covered this. Yes, one of you mentioned in between, start reading textbook. Yes, friends. Subscribe to Cerebellum. Start reading textbooks also side by side. There is no substitute to textbooks, no doubt. Okay. Then there was a question on CRS, congenital rubella syndrome, pediatrics. Dr. Anand will also cover. I'll just tell you it leads to abortions, stillbirths, blueberry skin lesions. That is the skin manifestation. but classical triad that we teach in PSM, because MR vaccine is included in the program now in many states of our country. So CRS will include sensory neural deafness, heart defects, and cataract. If there is infection in early part of second trimester, only deafness occurs. If there is infection after 16 weeks period of gestation, no major anomaly is seen. Then friends, there was a question on alcoholic with vitamin deficiency. Has to be thiamine, depends on the question if Wernicke-Korsakoff psychosis was mentioned in the choices or not. Then a student mentioned there was a question on B12 deficiency, the unique manifestation we discuss in every session. Subacute combined degeneration of spinal cord was also there. A student mentioned that there was a question on impaired wound healing also. Vitamin C deficiency, collagen. Okay, friends, I feel most of the questions we have discussed. There were few other questions when I get those. Like one of the students was saying there was one question on water testing method. Okay. Parboiling also, there were more questions. Okay. So friends, what I'll do is I'll compile those questions also. Till now, I have discussed 20, out of which 18 should have been correct. I found one question difficult because it was totally new. That was Colombo plan. It was asked for the first time, not a logical question to ask because it is a 70 years old plan, not much in existence today, right? So friends, thank you so much for being a part of this PSM session. I'll request Dr. Apu sir to take over. Thank you so much, friends. Do well, get your balance right, and I'm sure you'll get wonderful result. Do let us know how your result goes. The time from here to result. Enjoy it. Thank you so much. All the best, friends. Okay, Dr.
Vivek,
Apu. Yeah.
Vivek sir, you got the light in the room?
Yes, sir. Thank you so much for your advice, sir.
And now we have the lady. The next is Dr. Priyanka. Are you ready? Dr. Priyanka, are you ready?
Ma'am, please unmute yourself.
Yeah, she's just doing it, I think. Yeah.
Yes, sir. Hello, sir. Good evening, everyone. Am I visible
Priyanka.
and audible to you people?
Absolutely, yes. And Priyanka, just want to tell you that all the students watching Cerebellum channels, they are in love with your teaching.
I have done it. Trying to share my screen now.
All the best to you.
Thank you. Thank you so much, sir. Thank you so much.
All right.
Thank you. Thank you. Just sharing my screen and starting. Give me a minute. I hope you can see my screen.
Yes, we can see your screen. Yes, go on.
So good evening, all dear students. Okay. Is my screen visible, audible to you guys? Kindly, can you write in the chat box? Can you see? Okay, I guess you can see it. Okay. Okay. So good evening, all of you. I hope you have done great today in the exam. Yes. So now don't worry about the result. You have given your best shot. Whatever best you can do, you have already done. Now don't worry about the result and just do the recall question, but don't panic regarding that. That is just an advice. Now, many educators are waiting for the discussion till evening. So without wasting any further time, I'm just starting it, right? So in the microbiology, I have collected till now 12, 13 questions, but I'm not getting all the options. So you people have to help me for the options. And after in a day or two, I will come with a detailed analysis. First here, we will discuss the questions. You will help me in the options and we will try to come on the correct options. I will help you for the correct options, right? So let's come. The first question, I guess, Dr. Vivek Jain have already discussed. It's a common question in microbiology also, in PSM also. So I guess the tetanus vaccine, is it already done? Right. So in the question, I guess the clean wound was mentioned. In the tetanus vaccine, we see the first thing we have to see is the type of the wound. Is the wound is tetanus prone or not tetanus prone? What do you mean by that? If the wound is clean, if the wound is less than 6 hours, and if the wound is less than 1 centimeter, like it's superficial, not deep penetrating, and it's clean, it doesn't contain any dirt, saliva, or anything, then it's considered as non-tetanus prone wound. What was mentioned in the question? In the question, was it a clean wound? Exactly mentioned. The second thing you have to see in the tetanus vaccine is this thing. The last vaccination was done how many years ago? Is it within 5 years, 5 to 10 years, more than 10 years, or immunization status is unknown? So I guess what I found from the students, they are saying clean wound was mentioned and more than 10 years, the last vaccination. According to that, if the wound is clean, so it is non-tetanus prone, and within 10 years, so answer will be single dose, 1 dose. Yes. So clean wound, no bleeding, yes. So correct answer will be 1 dose of the tetanus. What all options you were having in that question? You may be having the options from this table only, right? You may be having the options from this table. Okay. Okay. Done. Okay, 10 years back. So I guess, yeah, the correct answer is 1 single dose. Coming on the next question, I guess this is already discussed by Dr. Vivek Jain. The Koplik spots, the typical Koplik spots and the rash on the face. You got the image of the Koplik spots, or you got mentioned about the Koplik spots? I guess you got the image. It was image-based question. So what are Koplik spots? You already know, I guess. Koplik spots are the lesions in the buccal mucosa just opposite to first and second molar. Can you see the first and the second molar? These are the whitish lesions. These are typically seen in measles. We all know that. And the rash is maculopapular. So yes, the rash, yes. So you got, what did you get? You get an image. You get an image on the rash and Koplik spot both? Or you got one image showing the both? So what was the exact question? And what were the other? Okay, no image. Okay, no image. Great, great. So coming on the next question is already discussed, the congenital rubella. So sir already discussed the, the typical triad we see. There are many findings in that, but the typical triad is sensory neural deafness, eye abnormalities, and congenital heart disease. In congenital heart disease, the specific is PDA, right? This question is already discussed, so let me skip it. So next question, yes, the next question, you got some umbilicated papule, the question on some umbilicated papule. Did you get this image or you get this image? So what image? So it was an image-based question. So you got only theory. You got only theory in this question, or you got an image in this question? So I guess students were saying that you got an image in this question. It was the image showing Henderson-Peterson bodies. The inclusion bodies were there. Yes. What was, I'm waiting for it. Yes. Okay. Molluscum in HIV. So patient was having HIV. HIV patient with papules. Okay. If the patient is immunodeficient, it always attracts the viral infection. He is prone to have the viral infection. Okay. Only theory was there. Okay. So umbilicated papules. I'm coming on rotavirus question also. Don't worry. It is there. Yes. So the rash is typically on the face, on the trunk, on the extremities. You can see typical umbilicated rash. The answer is Molluscum contagiosum, and it is having Henderson-Peterson bodies. The next question was on the treatment of gonorrhea. Was it a question? Students were saying there was a question on treatment of gonorrhea. On the treatment, what's the drug of choice on treatment of gonorrhea? It's an STD, right? So males present with urethritis, females present with cervicitis. It can occur in neonates also from the contaminated genitalia of the maternal, maternal genitalia during vaginal delivery. So what was the exact question? Can you help me with that? Okay, there was the image of the whole body. Okay, great. So what is the drug of choice? The drug of choice is the third generation cephalosporins. So any option in the third generation. Okay, I'm audible, I guess, right? Yes. So yes. So what were the options you are having? The correct answer will be the third generation of cephalosporin. Yes, ceftriaxone. If ceftriaxone was the option, It is the correct answer. Any third generation cephalosporin will work. And if chlamydia is coexisting, then azithromycin or doxycycline. I guess it is not mentioned in the question that there is a coexisting chlamydial infection. If it is not mentioned, they are asking only for gonorrhea, then go with third generation cephalosporin. I guess it's audible now, right? Okay. So the correct answer is third generation cephalosporin. The next question was on the Plasmodium falciparum, the malarial parasite. So can you tell me the typical antigen present only? There are 4 plasmodiums we are having now. So very fantastic medical officer. I always tell this mnemonic to the students. It's Vivax, falciparum, malari, and ovale. The 4 type of plasmodium we have. So this is the mnemonic I always tell to the students, right? Now falciparum, we have to differentiate from the other 3 because falciparum causes complications in malaria. Other 3 do not cause complicated malaria. So the treatment of falciparum differs as compared to treatment of other 3. In India, we don't have malaria or rarely have malaria and ovale. In India, we have Vivax and falciparum usually, right? So we have to differentiate other 3 from the falciparum. So how do we do that? What is the typical antigen which is present only in falciparum and not in other 3? And what is the common antigen which is present in all 4? So the common antigen which is present in all 4 is LDH, parasite LDH. It is present in all plasmodium, right? But it is HRP, that is histidine-rich protein 2. It is present only in falciparum. So these are this test is immunochromatography, you may be knowing. It is a pregnancy kit-like kit. So we just put the blood sample of the patient here. So the sample will travel ahead and we are having 3 lines. The third one is always controlled. The first is anti-falciparum. This contains antibody against the histidine-rich protein 2. And this contains the antibodies against LDH, right? So if this line is coming positive, means it is malaria. Any of the 4 malaria is positive. And if this is also coming positive, here you can see this one is negative, but this is positive. So it is non-falciparum malaria. It is malaria because the common antigen is positive. The LDH is positive, but HRP2 is negative. And if both are positive now, that means it is falciparum malaria. So immunochromatography is it's performed. So yes, so the correct answer is HRP2. I guess you were asked the antigen. Now, what were the other options? Can you help me with other options apart from that? So falciparum is having a unique antigen which is not present in any other plasmodium. It is HRP2. The HRP2 is the correct answer. So coming on the next question. The next question, I didn't get the complete history. There was a history from a mail, the mail from Rajasthan. So you got one of the image of one of the, form. So what is it? One of the morphological form. Which image you got in the question? So history from the Rajasthan or Bihar and one of the morphological form from this image, So it is indicating towards leishmania, right? So in the leishmania, out of these 4, we are having 2 forms, amastigote, promastigote. So which image was given to you in your exam? Did you got amastigote or promastigote? Which image you got in your exam? It was a kinetoplast. You didn't got an image. So kinetoplast, what was the exact question? So this is the nucleus you can see. So we have to see the nucleus, the location of the kinetoplast in respect to the nucleus. If the kinetoplast is anterior to the nucleus, it can be amastigote, promastigote, epimastigote. But if the kinetoplast is posterior to the nucleus, it is trypomastigote. So what was mentioned? What is the location of the kinetoplast in respect to the nucleus? So can you help me with that? Okay, it was not an image-based question. Okay. Okay, just mention kinetoplast is seen. So if kinetoplast is seen, answer has to be one of the flagellate. It can be any of the hemoflagellate, right? So hemoflagellate, it can be leishmania, it can be trypanosoma. Now, what other findings or clues we were having in the question based on that? So the answer can be trypanosoma, brucei, cruzi, anything. Depending on the other clues, we can decide. Yes. So leishmania tropica was there in the option. Okay. Within the macrophages. So it is obligate intracellular, somewhat intracellular parasite was there. So yes, everything is fitting in the leishmania. So I guess any other clue given in the question? Is it hematuria and abdominal pain? Okay. Okay. So I will come with the exact question. So I'm not getting what were the exact question and the options were there. So let's move ahead. So the next question was on filariasis, the lab diagnosis of the filariasis. So the lab diagnosis of filariasis, the typical test is DEC provocation test. So we perform DEC provocation test. Why? Because the microfilariae come in the blood during night. That is 9 p.m. to 2 a.m. in the night. But it's not possible the blood collection during the night. But DEC provocation test was there in the option. Was DEC provocation test was there in the option? Okay. Okay. Okay, 2 questions were there. Some students are saying 2 questions were there on Leishmania. Leishmania Donovan bodies was there. So you got Leishmania Donovan question also, the LD bodies also. So in the LD bodies, you typically get the macrophage. Inside, this is the macrophage. This is the nucleus of the macrophage. And inside the macrophage, you get the amastigote form. So amastigote form present inside the macrophage. This complete structure is known as LD body. So LD body is typically a macrophage who has engulfed the amastigote form of the parasite, the Leishmania parasite. So that may be the second question, I guess. Right. Okay. Okay. So coming on this question, what was the exact question on filaria? Can you help me with the options? Question was on lab diagnosis of the filaria. Okay. So lab diagnosis of filaria. So the various options you may be having, one is DEC provocation test. After that, we collect the blood. And after collecting the blood, we can do a direct microscopy, the thick and thin smear. So we get the microfilary in the blood. The microfilary of Wuchereria bancrofti, the nucleus do not reach to the tip. That is the unique feature as compared to all other filarial worms. The nucleus do not reach to the tip, and it is a sheath-hid parasite. So what was the option in this question? Blood testing for microfilaria. Yes, if it was an option, that will be the correct answer. The blood testing is done after DEC provocation test. Right. The next question was on rotavirus. Rotavirus lab diagnosis. So rotavirus lab diagnosis, we can do electron microscopy in which we get typical wheel cart appearance. If it was the option, it may be the correct option, or as detection of viral antigen in the stool. That is the best test. Detection of viral antigen in the stool by ELISA. I guess this is the correct answer. You got this as the option. Yes. Okay. Filarial antigen positive. So what is the investigation is asked now? The lab diagnosis for rotavirus. So correct answer is detection of viral antigen in the stool. You got this options, I guess. Right. The other option, detection of viral antigen in the blood and detection of antibodies, that is serology, is also there. So serology we can also perform, but it is best to detect the viral antigen in the stool. If electron microscopy an option showing the typical wheel cart appearance? Yes, electron microscopy was there as an option? I'm asking you. So here, if electron microscopy is not an option, we will go with detection of viral antigen in the stool. Right. The next question was on the hydrated cyst, I guess. Hydrated cyst, typical question on the hydrated cyst. The answer was Echinococcus granulosus. Was there a question on hydrated cyst? Can you help me with options and the other clues given in the question? Till now, I didn't get the correct question, complete question and the option, but there was a question on the hydrated cyst and Echinococcus granulosus, that is dog tapeworm. So what was the exact question? Okay. Okay. If electron microscopy is not there, in the last question students are asking, electron microscopy is not there, we will not go with light microscopy because rotavirus is a virus, it will not be visible in light microscopy. None of the virus can be visible in light microscopy. Now, common sense. It has to be electron microscopy. If electron microscopy is in the option, you can go with that. If it is not there, because the appearance is very typical, it's wheel cart appearance. If it is not in the option, you will go with detection of viral antigen in the stool, not in the blood, in the stool, right? It is a virus which causes gastroenteritis. So it is secreted, it is shedded in the stool, and we can detect that. Yes. Okay. What was the question on the Echinococcus? Can you help me with that? So floating membrane. So the treatment is asked. So in Echinococcus granulosus or hydrated cyst, the treatment is asked to you. What were the options given in the treatment? Radiological image was given. Okay. You got the radiological image on the liver cyst. It causes a cyst in the liver followed by lung. 80% time it is in liver, 20% time it can be in the lung. Okay. So liver abscess was there. You got a question on the liver abscess and the treatment options were asked, right? Okay. Got it. So medical management. So in the medical management, We can do the surgery, but surgery will be later on. In the medical management, we will give the antiparasitic drugs can be given. Okay, so let me, please give me all the options. I will come with the detailed analysis and all the correct options. Okay, got it. And the next question was on CMV. Yes, pair. If pair was there in the option, you can go with the pair. Right? That is first what we will do now. The best treatment here, if there is a cyst in the liver, first we aspirate a little bit, 10 or 20 ml fluid from that. Right? So first we aspirate, then we inject the antiparasitic drug into that so that it shrinks, and then we again re-aspirate. This procedure is known as pair. This procedure is known as, so first aspirate, then inject, and then again re-aspirate. So we do this. If pair was there in the option, you can go with pair, right? That is the best management. And if it is not, if there is a complication in pair or there is recurrence, then we do the surgery. Surgery is not the first line management. The first line management is always pair here. Yes, so pair was there in the option. Pair is the correct answer. That is the treatment of choice in case of hydatid cyst nowadays. So pair is the correct answer, in which we aspirate a little bit, then inject, and then again re-aspirate. We inject the antiparasitic drug that will cause the, that will cause the killing of the parasites, the Echinococcus granulosus present in the fluid. Now coming on the next question, in CMV, you got typical question on owl's eye appearance, right? So CMV is one of the virus which causes intranuclear as well as intracytoplasmic inclusion body. So the inclusion bodies are present in both the cytoplasm also, the nucleus also. Along with measles, there are only two viruses, the measles and CMV, which causes inclusion body in the nucleus also and cytoplasm also. And it typically gives owl eye appearance. You can see here it's looking like the eyes of an owl. It's typically owl eye appearance. So the question was on owl eye appearance. Okay. Yes, the correct answer is CMV. Was it a straightforward question? The owl eye appearance inclusion bodies are seen in CMV. Okay. Owl eye appearance in stool. What was the exact question and the other options? Can you help me with that? So till now we couldn't found all the options given, in your exam. But I'm trying to get all the options from students only. And again, we will do a detailed analysis in a day or two. So till now I got only these many of questions, but I will try that till tomorrow, all the questions will be gathered from microbiology. And that's it. So I would like to hand over to Dr. Apur, sir.
Thank you very much. Thank you very much, Priyanka. Thank you very much. We'll just request you to stop sharing the screen.
Okay.
Just stop sharing the screen.
Thank you.
Thank you very much. It was fantastic teaching as expected, Priyanka. So it was fantastic. And now we'll have dermatology by Dr. Srinivas sir. I welcome you on behalf of the Cerebellum family. And you can just switch on your video, sir. Yes, Dr. Srinivas, welcome. We can see you now. Over to you now. You and the students now.
Okay. Thank you so much, sir, for the introduction, and good evening, everyone. Audio working? Audio and video are working?
It is fantastic.
Okay. Thank you so much, sir, for confirming. So I will start sharing my screen. So is my
Yes, it is visible.
Audio and screen visible?
Fantastic. It is fantastic. Yes, Dr. Srinivas, welcome. We can see you now. Yes, it is fantastic. We can see you. Go ahead.
Yes. My screen. Is my screen visible?
Yes, it is visible.
Okay, thank you, sir.
So,
myself, Dr. Madhiren Srinivas, friends, your dermatology faculty. So these are the recall MCQs. And what we will do is I have got the questions and the few of the options. I would request you to please add on any other options which you remember were there in the actual exam. And also do like this video and also subscribe to the channel. And if there are some mistakes in this, questions or options, please do put your, comments in the comment section in the live chat, so that we are going to add on the points. And I'll try to make a separate video for dermatology recall, and we'll post it in the cerebellum. So this is very important for FMG and INSET as well. Okay. So this was the question which students told me. What is the most likely complication which can occur in this patient? And this was the image where a child having a pigmented lesion over the face, which is covered by hair, was given. So was this MCQ there? So if at all this question was there, then please remember the answer is going to be malignant melanoma. So this was the, so please confirm if this was the actual picture. And this was the image where a child. Okay. So please remember, friends, this is a congenital melanocytic nevus, so which can be present from the birth, and there will be well demarcated hyperpigmented plaque which will be covered by hair, hypertrichotic. And please remember, whenever there is a giant congenital melanocytic nevus which is more than 20 centimeters in size, there is a risk of development of melanoma. Okay, so this is what you have to remember. And this is how the congenital melanocytic nevus can be present elsewhere over the body also, along with the face. And we not going to discuss the differentials. Why? Because of the time crunch. And this is Sturge-Weber syndrome, which will present with pink or red lesions over the face in a unilateral fashion. And these patients are going to have an increased chance of development of glaucoma, which is related to the eyes. Okay. So some student was telling that this question was also asked. Was this question asked? No explanation, no explanation. Okay, okay, fine. I will try to keep it the minimum. So this is the next question. So please just type in the comment section. I will read that later on after this video. If Sturge-Weber was given. Sir, please no explanation. Okay, okay. So, okay, fine. So this was the question which was asked. So what is the allergen responsible for the dermatitis? So I got this image from the students. I don't know if it is true or false. Almost similar. Okay, the answer is going to be option B, which is paraphenylene diamine. So please remember, friends, PPD is called the short form of paraphenylene diamine, which is present in hair dye. Okay, hair dye. And this is a case of allergic contact dermatitis to the PPD, which is present in the hair dye. So these are some of the examples of ACD. So quickly, just we'll see. So this is PPD, which will be present in the hair dye. So of late, there are many brands which are coming up with PPD and ammonia-free hair dyes. Okay. And these are some other ones, metals, nickel, and in the antibiotic neomycin, and in the cement, there is going to be potassium dichromate, and in the bindi, there is going to be PTBP, para-tertiary butyl phenol. Okay, and this question was this question asked in the exam? HIV patient with these mucosal lesions, what is your diagnosis? This was the question which students told me it came in the exam. Yeah, I'm not trying to tell any explanation. Okay, I'm just going with bullet train speed. So was this question there in the exam, in the actual exam? Please do give a like to this video if this was there. Same pick. Okay. Yes. So please remember, immunocompromised patient whenever has these kind of, violaceous plaques, papillonodules over the body or in the mucosa, you should always think about Kaposi sarcoma. And actually, in fact, this exact picture was taken from New England Journal of Medicine, NEJM. Kaposi sarcoma of the oral cavity, and you can see this was taken directly from the journal. Okay, so this is related to HHV8, human herpes virus 8, Kaposi sarcoma. Okay, so I'm not discussing any explanation. We'll deal with the explanation in a separate video. And this was the next question: HIV patient with these skin lesions, what is the diagnosis? Was this MCQ there in the actual exam? If there, please give the like to this video or put in the comment section yes. Same questions. Was it there? And if it was there, please remember this was also taken directly from a journal. This was also taken directly from a journal. And this is a case of molluscum contagiosum. Molluscum contagiosum. This is taken from IJDVL. Indian Journal of Dermatology, Venereology and Leprosy. Yes. So please remember, this is a case of disseminated molluscum. Disseminated molluscum. Okay. This is the, IJDVL article. You can read this. The video will be there. So usually it will present with few pearly white papules, umbilicated papules. This is the umbilication. Okay. But what happens is, in the case of immunosuppressed person, that is HIV/AIDS infected individuals, the molluscum contagiosum is going to have very atypical presentation. So there will be extensive lesions and recalcitrant lesions, and giant molluscum can be there. So this is the answer is going to be molluscum contagiosum. And this was the next question which students told me, female with acne resistant to antibiotics and isotretinoin, what will be the next step? Was this question present in the exam today? Yes, I'm not trying to explain anything. I'm going at jet speed. Was this question there in the actual exam? Almost similar. Okay, so please remember, whenever there is a female having acne which is resistant to antibiotics and isotretinoin, we should always think about a possibility of hyperandrogenism. I hope you all remember Hyran syndrome. Hyran syndrome. Okay, I am not going into the details. It is associated with some hormonal imbalances. So what we should do is, we should ask about history of hyperandrogenism, or we should do investigations which are related to androgen levels. In the hormone levels, we should try to assess. Okay, this is all the information. You can read it anytime. Okay, this question, genital ulcer which was painless and lymphadenopathy which was painless was given in the question. What is the diagnosis? Was this the actual question, or is there any change which you want to make? Please put your changes in the comments. I'm not sure about this question, whether it is correct or wrong. So there is a slight lag of some 10 or 15 seconds, because of which after I am asking, I'm not able to see your live chat.
That's a normal lag in videos.
So please remember, if I will try to, yes, same. So if it was same, then please remember, instead of remembering syphilis as if you would have remembered it as syphilis, then you would have answered it correct, because ulcer which is painless, lymphadenopathy which is painless, both are painless, is present in syphilis. Okay, the diagnosis will be syphilis. If this was the exact question, if there is any difference, please put your answer in the comment section, friends. So I will try to give the how to approach in the separate video. White finger, this was explained beautifully by our Vivek Jain sir. So it's vibrating machinery. So this is all the data about that. A lady with vaginal discharge and cervical erosion. So this question, Dr. Reina ma'am, our gynecology faculty, is going to explain. Scurvy is due to collagen deficiencies, collagen deficiency because of vitamin C deficiency. Okay, I hope these were the MCQs which were asked. Were there any more MCQs which were asked, or related to dermatology, or do you think these were the only questions which were asked? So please just confirm in the comment section. Perineum ulcers, painless, gray kit. First question answer. First question answer. It was which that is malignant melanoma. So I have told you that malignant melanoma. Syphilis, granuloma inguinal. Okay, glaucoma. No, friends. Glaucoma, that is related to port-wine stain. Okay, Stooge-Weber syndrome. I hope these were the only questions. There are no more questions. Keloid on the chest was asked. So what were the options related to the keloid? Can you please put the options? Trophic ulcer in the foot and keloid image. No, this all. Lower abdominal pain with herpes, which kit? So these questions I have not got from the students. Were these questions actually there? So previous chest trauma, keloid. So what were the options? Keloid. What was the question related to keloid? Can anyone please put many question from STD? Okay, keloid. I think only keloid came if there is a trauma history and that is any surgical history, followed by which crab-like encroaching lesion is present over the chest. You should think about a keloid. Okay. So I think these were the only questions. So I will rest my case. So I hope every one of you did it great in the exam. Next, try to eat properly, have a good sleep. Also try to see the recall if you are not kind of anxious or panicky student. Okay. Otherwise, just take a chill pill and relax for the rest of the day. Go out with your parents or with your friends and enjoy and have a good sleep, because you are deprived of sleep in so many days, most likely.
Thank you very much, Dr. Srinivas. You can stop sharing the screen now.
Have a good sleep. Also try to see the recall.
All right. Now we have the next teacher, who is a great clinician himself. And why I'm speaking this, because today's paper was more of clinical paper. And as the time will go, the percentage of clinical questions is going to increase. So as far as the clinical subjects are concerned, the teachers who are into active practice and into academics together are going to have the edge and going to benefit the students more. So with us, the next is Dr. Gaurav Nagpal sir. 3 things about him. He's a great eye surgeon. He's a fantastic teacher, but more importantly, he's a fantastic human being, and it's very rare to find all 3 in one. So over to you, Dr. Gaurav sir.
Good evening everyone, and Dr. Pur, बहुत thank you. मैं हमेशा कहता हूँ, और I always say that people who are like-minded, they tend to come together. So this is what is Cerebellum. यहाँ पर जितने भी faculty हैं, all of them are really great, and all of them are doing their best to help the students. We want the best faculty to come from the students itself. So many of you are going to be a part of Cerebellum in future also. So quickly, I'd like to share my screen. Let's see. Okay. Is my screen visible?
Abhi nahi, sir. Abhi nahi. Now it is visible. Visible now.
Now it is visible. Okay.
Yes, sir. We can see now.
So nice of you. Thank you for this confirmation, Dr. Pur.
Sir, there will be a slight delay on YouTube. You focus on the stream.
Yeah, sure.
Go on, sir.
So I will. Yes. Thank you, Dr. Pur. अच्छा दोस्तों, एक चीज very important. Those who are watching this live, do not judge yourself. This paper is part of the big thing called life. ठीक है, ये एक सिर्फ छोटा सा पार्ट है. Do not never judge yourself. हर कोई टॉपर नहीं होता. मैं हमेशा कहता हूं कि आज की डेट में जो मेरे बैच का टॉपर भी है, वो भी आंख दिखाने के लिए मेरे पास ही आता है. क्लियर है ना? सो ऐसा नहीं, आई वॉज नेवर अ टॉपर इन माई बैच, आई वॉज नेवर अमंग्स द फर्स्ट इन माई बैच. तो हमें टॉप नहीं करना, हमने जो हमारा चॉइस है हमने वो चाहिए. दैट्स इट. एंड आगे और बहुत मकाम है. जरूरी नहीं है कि इसमें जो हुआ वही सब कुछ है. ठीक है, यू कैन ऑलवेज सक्सीड इन लेटर इन लाइफ ऑल्सो. यू कैन बी अ ग्रेट सर्जन. जरूरी नहीं है कि हर टॉपर एक अच्छा सर्जन होता है. नहीं, नॉट ऑलवेज अ टॉपर इज अ गुड सर्जन. ठीक है, सो डोंट जज योरसेल्फ, रिलैक्स. जैसे अभी डॉक्टर श्रीनिवास ने कहा, टेक अ चिल पिल. इट्स वेरी इंपॉर्टेंट टू टेक अ चिल पिल. ठीक है, सो विल फर्स्ट क्वेश्चन डिस्कस द ऑफ्थाल क्वेश्चंस. 3-4 क्वेश्चन मेरे उसमें आए हैं. एक आया चेरी रेड स्पॉट का, वेयर आई एम नॉट वेरी श्योर कि ऑप्शंस क्या थे, बट आंसर जो मुझे समझ में आ रहा है वो ये कि उसका आंसर टे सैक्स था। ठीक है, चेरी रेड स्पॉट में इस तरह का एक कई बार इमेज बेस्ड क्वेश्चन आता है। ठीक है, सो इसमें इमेज बेस्ड क्वेश्चन आता है, एंड आई ऑलवेज गिव अ निमोनिक चेरी रेड स्पॉट में कि इट इज बी स्टिंग। द निमोनिक दैट आई गिव इज बी स्टिंग। जब बी काटता है तो आपको स्टिंग जैसा बन जाता है। तो इट द ऑप्शंस दैट वर गिवन आर Berlin's edema, cyanosis, Tay-Sachs, ischemia, Niemann-Pick, and gangliosidosis. So this was a straightforward question. Tay-Sachs, ठीक है, बहुत ही straightforward question था। इसको ये तो स्पॉटर था, सिटिंग स्पॉटर। ठीक है, so there is this question was there. Then शायद एक image based question था which had an image showing a mass on the limbus. ठीक है, एंड शायद ऑप्शन उसमें टेरिजियम, पिंगिकुला और लिम्बल डर्मोइड था। ठीक है, तो उसके अंदर सिंपल सा ये अगर बन रहा था तो इसके अंदर आंसर जो बन रहा है मेरे हिसाब से लिम्बल डर्मोइड बन रहा है। इफ इट इज देयर इज हेयर ग्रोथ, देयर इज सम टिश्यू व्हिच इज बीइंग सीन देयर, तो वो लिम्बल डर्मोइड बनेगा। टेरिजियम वाला, it was an image based question, so until unless I come across what kind of image was there, बताना मुश्किल है। ठीक है, टेरिजियम जो बड़े डिफरेंट फॉर्मेट्स में मेरे को पता लग रहा है वो कि इट वाज अ लिम्बल डर्मोइड। ठीक है, सो देयर वाज डर्मोइड ऑप्शन। हाँ ठीक है, लिम्बस पे अगर होगा तो उसको आप लिम्बल डर्मोइड बोलोगे। ठीक है, डर्मोलाइपोमा, डर्मोलाइपोमा एक डिफरेंट चीज हो जाती है। इट इज ऑन द कंजक्टाइवा। पिंगिकुला कंजक्टाइवा पे होता है। यस, पिंगिकुला इज प्रिकर्सर ऑफ द टेरिजियम कह सकते हैं कई बार। ठीक है, इलास्टोटिक डीजनरेशन मिलता है। अच्छा, इट वाज कई जगह मेरे को मिला है कि देयर वाज एन इमेज बेस्ड क्वेश्चन, बट अगर नहीं था और लिम्बस पे है तो वो था, इट वाज नॉट ऑन लिम्बल। ओके, if it was not on limbal then the answer would be pincicula. It was on limbus तो फिर वो limbal dermoid बनेगा। limbal dermoid was not an option. Dr. Biswal, are you confirmed कि limbal dermoid was not an option? हाँ, बेबी आई में भाई limbal dermoid जो होता है वो congenital होता है। ठीक है, so it grows with age also, तो बेबी आई में मिल सकता है। as you can see in this question also, इसमें भी जो इमेज है इसमें भी लिम्बल वो है। भाई पिंकिकुला लिम्बस पे नहीं होता, इसलिए इट इज नॉट पिंकिकुला। पिंकिकुला विल नॉट बी ऑन द लिम्बस, सो दैट इज व्हाई। ठीक है, चलो विल एज वी गो अक्रॉस विल कम अक्रॉस द क्वेश्चन। ठीक है, ये एक बहुत ही सिंपल सा क्वेश्चन था, राइट साइडेड विजन लॉस। ठीक है, तो ये तो स्पॉटर था। राइट साइडेड विजन लॉस हमेशा बताया है, अगर एक साइड का मिल रहा है तो इट इज होमोनिमस। ठीक है, मैं हमेशा कहता हूं कि इफ देयर इज वन साइडेड, ठीक है, जैसे इसमें इस वाले इमेज में लेफ्ट साइडेड विजन लॉस दिखा रखा है, होमोनिमस होता है एक सिंगल साइड का। ठीक है, होमोनिमस होता सिंगल साइड का। तो अगर राइट साइडेड विजन लॉस है, राइट साइड का विजन लॉस है, तो लीजन जो होगा वो लेफ्ट साइड पर होगा, लेफ्ट ऑप्टिक ट्रैक्ट। ठीक है, इफ देयर इज यस होमोनिमस, ठीक है, राइट साइडेड होमोनिमस हेमियोनोपिया, तो लीजन लेफ्ट साइड के ऑप्टिक ट्रैक्ट पे होगा। वेरी वेरी सिंपल क्वेश्चन, इट वाज राइट होमोनिमस हेमियोनोपिया, यस, तो लेफ्ट ट्रैक्ट। ठीक है, लीजन साइड लेफ्ट ट्रैक्ट। ठीक है, देयर वाज there was some question on cataract, I believe, या तो उसके ऊपर इंडेक्स मायोपिया वाला क्वेश्चन था। ठीक है, ये सारे के सारे प्रीवियस ईयर क्वेश्चंस है, ऑल ऑफ देम आर प्रीवियस ईयर क्वेश्चंस। यस, यू नीड टू फोकस ऑन द प्रीवियस ईयर क्वेश्चंस। यस, 80% पेपर हमेशा पहले वाले उसमें से आता है। ठीक है. So please focus on your image based questions, on your previous year questions. उसमें से these are, I always say कि rank बाद में आती है, पहले हमें selection में focus करना है. Selection आपका तभी होगा अगर आप previous year questions को correctly answer करेंगे. Only and only not making silly mistakes is going to get you through to the selection process. Once you are selected, then every question would matter where your rank lies. But if you are going to end up missing on sitters, spotters, तो फिर वो आपका miss होएगा. Index myopia is a part of a nuclear cataract. Nuclear cataract में, as there is change in the protein composition, there is change in the refractive index of the nucleus, leading to a nuclear cataract, and this is why it is called as index myopia, क्योंकि यहाँ पर उसका refractive index जो होता है वो denser होता जाता है. ठीक है. So there was, and was there an image based question also on sunflower cataract, rosette cataract? Some people are saying a diabetic cataract. कोई ऐसा image based question भी था? Snowflake was not an option. Okay. Sunflower cataract option में था. Okay. Image based question था myopia पे. Okay. Zonular cataract is a type of a congenital cataract. Zonular cataract is a congenital cataract. So was that also an option? Okay, some are saying zonular cataract bhi tha. Zonular cataract is a most common congenital cataract which causes vision loss. ठीक है. वो उसका exact options जैसे पता लगेंगे तभी हम उस चीज को confirm कर पाएंगे. We'll come back with this exact options. Okay, zonular was there. ठीक है. So one was zonular. Zonular में आपका एक zone होता है जो कि affect हो जाता है. So there are riders which are seen. So zonular के अंदर riders होते हैं. नहीं, zonular presenile cataract नहीं होता. Zonular is not a presenile. Zonular is a type of a congenital cataract. ठीक है. Rosette cataract is post-traumatic. Rosette is post-trauma. That is there. ठीक है दोस्तों. Okay. ठीक है. Good. So these are the 4 questions that I've come across. One on cataract, one on visual field defect, one on right-sided vision loss, and one on cherry red spot. Cherry red spot में शायद वो with organomegaly था, तो with organomegaly Tay-Sachs में मिलता है. With hepatosplenomegaly is in Tay-Sachs. ठीक है. These are the 4 or 5 questions that were there in opthal. We'll come back with more questions if they're there. So there is one question that was asked, ECC with IOL phacoemulsification. Okay. Don't worry, dear students, don't worry. Whatever questions were there, we'll come back with full answers. Okay. All the best, best wishes. Hope for a good result. Let us pray for a good result. Let us not get disheartened at any point of time. Okay. Yes, we are looking into it.
Thank you, Gaurav Nagpal sir.
Most welcome, Bhaiji.
You are looking like Ajay Devgan of Once Upon a Time in Mumbai. Now the next is Dr. Shrikant Verma, Anatomy. And you know, Shrikant, Dr. Shrikant, you can switch on your video, please. So Dr. Shrikant, let us together try to speak this poem by Dushyant Kumar, which is your favorite and my favorite too, right? So that is something like this. हो गई है बर्फ पीर सी अब पिघलनी चाहिए. श्रीकांत, नेक्स्ट लाइन क्या है इसकी?
करेक्ट सर, करेक्ट सर।
हो गई है पीर सी पर्वत, अब बर्फ सी अब पिघलनी चाहिए। अगली लाइन तो बताओ इसकी।
ट्राइंग टू रिमेम्बर सर, आपके सामने बोलती बंद हो जाती है।
अरे ऐसे मत करो यार, हर हिमालय से गंगा जरूर निकलनी
निकलनी चाहिए। करेक्ट सर, करेक्ट सर।
राइट, मेरे सीने में नहीं हो चाहे हो तेरे सीने में।
करेक्ट सर,
Right?
करेक्ट सर।
आग कहीं ना कहीं तो जलनी चाहिए।
करेक्ट सर, करेक्ट सर।
दिस इज
यस सर। हेलो सर, हेलो।
yes Shrikant, so
Yes,
now
sir.
you with who's going to lighten up the stage.
Yeah,
And
yeah.
anatomy, let's stay with English, let's stay with single liners and answers. Let's
Correct,
speed
sir.
up, right?
Yeah,
The students, there are about more than 2,000 students watching live streaming. That's
Sure.
phenomenal for the teachers, and there are 5 teachers already waiting with their next. Over
Yes,
to
sir.
you, Dr. Shrikant. Have a great time.
Correct, sir. Thank you. Hello, dear students. How are you? Hope you all did very well. So, with the anatomy 360 degree, we cracked the many integration with the different subjects. Okay, so we are starting. See here, in our integrated part, I told you the cranial nerve, definitely the question from the cranial nerve will be asked. Do you know the herpes simplex dermatome related question had been asked, and the cranial cavity EDH versus HDH, radiology integration, our medicine integration, yes, it has been asked. Please inform me. These all are the just 1 hour recall basis. If any correction, please inform us. Okay, yes, fine. So now try to understand, we have to learn this topic, pharyngeal apparatus. I told you 1 topic from the pharyngeal apparatus. This is our cerebellum PDF notes which we shared. Yes, I told you the pharyngeal apparatus question will be asked, and can you correct me that the question from the pharyngeal arch artery, 6th arch artery had been asked? Please inform me, we are right or how? Student, inform me the question from the pharyngeal arch artery, 6th arch. So we predicted very correct. Fine. So now come to the next, inferior alveolar nerve. 1 topic. Yes, inferior alveolar nerve topic we had seen the last time. The question had been asked if there is a submandibular gland surgery. Yes, there was a submandibular gland surgery. In lingual nerve was at the option, inferior alveolar nerve was at the option. We had seen in the 2019 the inferior alveolar nerve had been asked, and right now again in NEET 2023 this inferior alveolar nerve had been asked. Yes, snowcast, thank you beta, thank you. 6th arch artery had been asked, thank you for confirming. Yes, patent ductus arteriosus. So Venkatesh is saying patent ductus arteriosus had been asked. Thank you. So remember, pharyngeal arch artery we have to learn the cranial cavity. Now see here, yes, look at this point. We had discussed regarding the cartilage, collagen and cartilage, collagen related disease integrated with our, yes, biochemistry, our biochemistry, as well as you can say community medicine. Collagen related question had been asked, as well as 1 beautiful topic we had seen, this one, thyroidization of the kidney. I told you histopathology. So at that time, I told you the slide of the thyroid where there is a chronic pyelonephritis. So the thyroid, yes, our kidney will appear like the thyroid. That is a thyroidization of the kidney. Please inform me. Yes. 6th aortic arch, this all we are there. Patent ductus arteriosus, you all are right. Yes. Okay, no inferior alveolar nerve question. Okay, fine. I got the information. There was the question over the inferior. Okay, so we are removing this one. Thank you, Sarika, for informing. Yes, we have to change the aspect to learn our anatomy. Why? Because of the integration. See here, cranial nerve, it had been asked, pharyngeal apparatus, 1 question. Glands, the question over the parotid gland, there was the image of the parotid gland swelling, and they asked about the pain, and student informed that options were the fascia, investing layer of the fascia. Okay, so these are our different points. Yes, parotid swelling, great auricular nerve, this was our previous year question. Right now again the parotid swelling, this had been asked, auriculotemporal nerve or great auricular nerve, this all were in the option. Agree beta? Fine. Yes, glomerulus image was given. Fine. Now see here, thyroid, I told you the thyroid question will be asked, NEET PG 2020. So parotid gland, pancreas, parathormone, this time pheochromocytoma, this P had been asked. Okay, now look here, the salivary gland, I told you the salivary gland will be asked, and this time the parotid gland swelling had been asked. So remember, this was our topic, parotid gland swelling. Okay, yes. Now see here, such kind of the image earlier had been asked. Right now, the parotid swelling, the investing layer, few students are saying that investing layer of the deep fascia, that was in the option. Agree, beta? So now try to catch thyroid carcinoma. I told you the breast hernia and thyroid, the thyroid carcinoma. So right now, the medullary carcinoma of the thyroid integrated to the anatomy, it had been asked, as well as the question integrated with the ENT. Tonsillectomy operation was there. Yes, tonsillectomy operation and bleeding. Which artery is there? So your answer was a tonsillar branch of the facial artery. Okay, getting the point? Fine. Yes. Now also there is the question related to the thyroid peroxidase antibodies. Yes. In the surgery, integrated to the surgery, the question above the our inguinal hernia. Tell me, inguinal hernia question was there? Yes, beta. We are just looking for the topics. We are looking for the question. Okay. So inguinal hernia, where the question for the superficial inguinal ring. Superficial inguinal ring question was there. Answer was the external oblique aponeurosis. I told you that there is the one triangular opening. Anterior wall question will be asked. Yes, kidney related question, the putty kidney as well as the cranial bleeding. Yes, EDH and HDH. Yes, please inform. Yes, one student told me that tonsillar artery branch was there. Okay. Now see here the question in integration with the our orthopedics, common peroneal nerve injury, neck of the fibula, it was asked. One question. Parotid swelling, nerve affected, it had been asked. Also the right lung image where there was the middle lobe. And another question, venous drainage of the lower limb. Last 2 times there was the question from the NEET 2021 and 22 over the great saphenous vein. Right now the question had been asked regarding the our venous ulcer. Getting the point? Yes, you all are right. No deep inguinal ring, that was the our superficial inguinal ring. That superficial inguinal ring at the external oblique aponeurosis. Agree, beta? Fine. Yes. Now also there was the question histopathology. I told you histopathology related to the kidney, it had been asked. Now look here, the more questions. Yes, thyroid, tongue and the tonsil, already it had been asked. Yes, cranial bleeding, it is important, integrated with the your radiology, it has been asked. Fine. Cranial bleeding, this image we had learned. We had learned the extradural hemorrhage, intradural hemorrhage, subarachnoid hemorrhage, intracerebral hemorrhage. Okay. Yes. Yes, pain referring to the tonsil. Vipin, you are right. Pain refer to the tonsil. That is the glossopharyngeal nerve. You are right. Okay. Also, yes, right now no image from the our cadaveric image. Good information is that no image from the our cadaveric image. Yes, this question related to the bleeding, I told you. Upper limb. In the upper limb, the carpal tunnel syndrome. Yes, integration with our ortho and the medicine. Carpal tunnel syndrome, median nerve, and among the option, Guyon's tunnel syndrome was there. Ulnar nerve injury is there, but Guyon's tunnel syndrome, it was not the answer. Carpal tunnel syndrome had been asked. Okay. Yes. Please inform me. Thank you for information. Ulcer was on the plantar foot. Okay, done. Okay, it was not the venous sensor. Okay, fine. Glossopharyngeal nerve is correct answer. Yes, tonsillitis pain is referred to the ear. You are right. Glossopharyngeal nerve. And yes, breast related question had been asked, breast carcinoma. And right now the CEAP classification had been asked. This different question. Yes, giant cell tumor. I told you integrating with the your orthopedics bone tumor, giant cell tumor had been asked. Okay, yes, it was the NEET 2023. Necrotizing fasciitis. I told you the skin, superficial fascia, deep fascia. If you are cutting the deep fascia, then you can relieve the pressure. Yes, necrotizing fasciitis, arterial disease had been asked, as well as one question from the venous disease. Okay, yes, you are right. Fossa of the Rosenmuller. So from the, yes, beta, you are right, beta. Yes, Prashant, you are right. The fossa of the Rosenmuller from the pharynx, this had been asked. Yes. So right now, in our previous session, I told you the CEAP classification part, varicose vein. Yes, CEAP classification NEET 2023, it had been asked. Yes, you are right. Nasopharynx part. And right now, total pharyngectomy. So pharynx related question, total pharyngectomy had been asked. I told you one question from the pharynx portion. Yes, upper part of the esophagus question is sure. And right now there was the question, which question? Fossa of Rosenmuller. Okay. So I'm just discussing the topics. Okay, herpes simplexly. Yes, we had seen the herpes simplex virus dermatome involvement. So HSV related dermatome integration. Yes, integration with the dermatome, it is important. Remember, the anatomy direct questions are very less, but indirectly, if you will integrate with other subject, many questions you will find out. So this dermatome topic integrated with the herpes simplex virus, it had been asked. Okay. Yes, I told you the ligaments, abdominal ligaments, anterior abdominal wall is very important. Question from the ilioinguinal nerve, it had been asked. Superficial inguinal ring, external oblique aponeurosis. Superficial inguinal ring is located at the external oblique aponeurosis. This was the question. Okay. Carpal tunnel syndrome, it is not the test. Carpal tunnel syndrome, median nerve. Okay. Yes. But anatomy, remember, if you are skipping the anatomy, you cannot deal with any other subject. Every subject is beginning from the anatomy. Okay. So directly, indirectly, all the questions are coming. Yes, I told you question from the liver, pancreas, kidney. So from the liver, chronic alcoholic condition and pancreatitis, chronic pancreatitis situation was given. And also, I told you the putti kidney. Okay, I told you the putti kidney. So right now, putti kidney NEET 2023 integrating with the our surgery portion. So this question had been asked. Yes, correct. Laryngocele, laryngotracheobronchitis. Okay. Okay, John, many students are saying the superficial. See here, if there is a deep inguinal ring, in that situation, answer is fascia transversalis. Okay, but if there is the superficial inguinal ring, then answer will be external oblique aponeurosis. Okay, so we will look for that all the situation. Peritoneum. So over the peritoneum, I told you the anterior abdominal wall and the peritoneum. So the question over the retroperitoneal hemorrhage. Yes, sir. The question over the retroperitoneal hemorrhage was there. So this is the one another integration. ओ भाई क्या चल रहा है, ये एनाटॉमी का इंटीग्रेशन चल रहा है. रिमेंबर, एनाटॉमी यू हैव टू इंटीग्रेट ईच एंड एवरी सब्जेक्ट. एवरी सब्जेक्ट इज रिलेटेड टू द एनाटॉमी एंड एनाटॉमी इज रिलेटेड विद एवरी सब्जेक्ट. वी हैव टू चेंज द एस्पेक्ट. इफ यू आर नॉट अंडरस्टैंडिंग प्रॉपर्ली, गो फॉर द अवर बुलेट ट्रेन एनाटॉमी एंड द एनाटॉमी 360 degree. Okay beta, fine. And I'm just discussing the topics. I'm not discussing regarding the what is the question pattern exactly, what is the our explanation. Fine, I'm only telling about the our yes topics. This inguinal canal part, we had seen the direct inguinal hernia, indirect inguinal hernia. Yes, go for the our previous portion. Retroperitoneal hemorrhage had been asked. Okay, so this was the our different topic. Yes, I told you the andrology. At that time, the andrology, I told you, yes, remember this Fournier gangrene, it had been asked. So you have to learn the male genital organ as well as the female genital organ anatomy properly. So these all are the things. So final message, I'm not wasting the too much time. Remember, success is not the permanent and failure is not the final. So take deep breath. Okay, and go for your further things. कुछ दिनों के लिए बेटा बहुत अच्छे से relax करो and then watch for the result. Okay, so I am not wasting bus your all the time. I told you the different topics. So direct question from the anatomy, 5 to 6 question, but if you will integrate, many more questions are there. Okay, so thank you very much. Thank you, sir. Yes, I told you, I informed you all the things. Yes, thank you, sir.
Dr. Shrikant, you're done?
Yes, sir, done.
You have rocked the stage. So
Yeah, sir. But I had not wasted the time. So students, I want to inform you. I just inform you the topics. What topic? Exact framing we will do later, because there are the many recall. Students are saying this one. So exact framing we will do later. But I told you all the topic related to the anatomy and integrated to the other subject. Anatomy 360 degree.
Fantastic.
Yeah.
So now we will go to the next teacher, Dr. Dilip sir. And Shrikant sir, you can stop sharing the screen now.
Yeah, thank you, sir.
I love this, Zindagi Do Pal Ki. So, Dr. Dilip sir.
Hi, sir.
I have seen your stardom when I went to take a class in Chennai. And, you know, I was teaching one of my favorite topics, that the tumor of the lower end of radius is GCD till proved otherwise. This always comes in the exam. It came today also. Young man with low backache, morning stiffness is ankylosing spondylitis. It came back again. And suddenly I was speaking the third line and I saw all the heads turning at the back, more of the girls than the boys. And you walked in the class and they started clapping for you. I thought they were clapping for me when I looked around. There was a tall person, handsome guy walking on the stage with flowers. And I just remember that. And that's what you are to us and to the students. And I'm sure that the students are going to have rocking time with you. Your sessions on Saturdays on Cerebellum have been loved a lot. And I think there's only one moment when students can't like me, and that's when I am between you and them. So I'll better get away and you take over. Over to you, sir.
Thank you so much, sir. Thank you so much for all your kindness that you have shown so far. And I'm not going to waste a lot of time. Don't worry about that. I understand that students are having quite a long day. So let me share the screen straight away. Just hold on. Yep. Are you able to see my screen? Are you able to hear me? Yep, I think so. Can you see, guys? Can you see and hear me? Yeah. I think, yeah, right now only answers. Don't worry about, guys. I perfectly understand the pain that you are going through, basically. So it's not like about that I don't understand. Okay, fine. Let us move on to the questions. Look at the first question. So, I mean, this is something that emotionally connected me because many students have have messaged me that one Insta reel that I've put on different antigens exactly came in the exam. So that is the malaria HRP2, which was asked in Plasmodium falciparum. And the second question, this is the question that we have discussed in the PYQ and table session, the very first session that I took for Cerebellum Academy. And here is a case of a female cough, breathlessness, mid-diastolic murmur, prominent A wave in JVP. So what is the answer? It's very likely to be a tricuspid stenosis. That's it. You don't see prominent A wave in patients with mitral stenosis unless and until there is a pulmonary hypertension. So the right answer for this is TS. Okay. Now, this is the third question. This is also something that we have discussed in one of our TND discussions, test and discussion sessions. Surgical prophylaxis for a patient undergoing surgery. It's very simple. It is actually cefazolin. Number 4, a 13-year-old girl went out playing. I think this was a case of delirium because she looks confused and she looked irritable and she didn't pass urine since morning. Friends said that she had something while playing. What is the likely intoxication, the correct antidote? So I think the right answer is Datura, right? So Datura and the physostigmine combination. Okay. So because Datura is a anticholinergic, it's going to result in anticholinergic poisoning, we know that. And of course, like the antidote of choice is going to be a cholinergic drug like physostigmine. And I think one of the decay management part is something that's asked in exams, if I'm not wrong. So we have discussed so many times that flip therapy is the one that we have been using that stands for fluids, insulin, and potassium. So this is the right answer. I think we have to give 10 to 20 ml per kilogram per hour. Sorry for that. Let me add on. So 10 to 20 ml per kilogram per hour fluid is what is required. Along with that, we are going to add initial 0.1 units per kilogram bolus and then 0.1 units per kilogram per hour infusion. Okay. So the insulin that we're going to use is going to be a kind of a short-acting insulin. So that's commonly going to be regular insulin. That's what I'm going to use. So that's the right answer. Coming to the sixth question, I think they have asked something with regards to atropine fever. Okay, that's what they asked. I mean, they've used atropine for OPC poisoning. We don't only use atropine, it's atropine plus pralidoxim. So That was one question. And I think seventh question, it was pretty simple one. So they asked about strychnine poisoning and opisthotonus, like guy took some herbal medications who came with opisthotonus, and it's very likely to be a strychnine poisoning, right? Okay. So this is another question. I think it's an interesting one. Female hypertensive headache, CT was suggestive of subarachnoid hemorrhage. What is the next line management? I think the BP here was around like 180/100, if I'm not wrong. It was quite high. So the right answer for this question is going to be nimodipine. In a subarachnoid hemorrhage, like we're going to do surgery. Of course, yes, we have to clip the aneurysm. That's different. But here the patient is hypertensive. So you have to stop the BP from rising further, and you have to reduce the BP at least to SBP of less than 140 to 160. So that's the reason why we're going to use nimodipine. It's one of the drugs that's exclusively approved for subarachnoid hemorrhage. And coming to the next question. So you have a patient with bronchial asthma who has stopped medications, now present with syncope and palpitation. So this was some arrhythmia. I'm not very sure what arrhythmia it is. Okay, I'm not very sure what arrhythmia it is. That was some arrhythmia. You have to say what is the arrhythmia. So because the patient was asthmatic, I'm not going to use propranolol. So the right answer for this will be a cardioselective drug like esmolol. I think there was a patient with mask-like facies who presented with Parkinsonian features, had visual hallucinations, and there was a picture of a Lewy body. So it's a straightforward Lewy body dementia. There's no doubt about that. And there was a question on Koplik spots, and there was a generalized maculopapular rash as well. The right answer for this is measles, easy one. And this is something that I've been telling for so long. So it's basically SEEP classification, right? So that's something that's been asked regularly every now and then, every single exam. It's a classification for varicose veins. So 13th question, I think there was a question on Fromen's test, which is going to test the ulnar nerve, which in turn is basically a test of adductor polysis. And there was a case of smear negative presumptive pulmonary TB with X-ray suggestive of tuberculosis. What is the next step? You're going to do CBNAT. People are having doubt, can look at this. Smear negative, but chest X-ray suggestive of TB. The next step is going to be CBNAT. Okay, that's the right answer for that question. And coming to the 15th question, you had a 13-year-old child with angular cheilitis, UMN-type palsy, absent ankle reflexes, absent proprioception and vibration sense. It's a classic subacute combined degeneration of the spinal cord. The reason being it's going to affect the corticospinal tract, causing UMN-type of palsy. And because it's going to cause peripheral neuropathy also, you're going to result in absent ankle reflexes, and it's going to affect the dorsal column. So going to get absent proprioception and vibration sense. I think there was a question on sacubitril valsartan. I think they asked on ARNI. So they asked the mechanism of action, I guess. So that was a question on sacubitril valsartan combination. And it's one of the straightforward cases, that's membranous nephropathy, where they mentioned about the spike and dome appearance in electron microscopy. And I think there was another question on post-streptococcal glomerulonephritis as well, which was not responding to treatment. So it was basically a case of type 2 RPGN, which is immune complex based RPGN. And the 19th question was so simple. Okay. So that's the pellagra one, the 3Ds, the dermatitis, diarrhea, and dementia. And classic history of ankylosing spondylitis, low backache, like young to middle-aged man. So straightforward, it's an ankylosing spondylitis case. And there was, I think, an X-ray of a silute sign with right middle lobe consolidation. And there was another CT scan. So there was an alcoholic who came with a CT scan, which is suggestive of a hemorrhage, but the alcoholic history itself is straightforward giveaway. It's going to be a subdural hemorrhage, nothing more than that. And there was another question, a medical student with picture showing exophthalmos, palpitation, sweating, tremors. What investigation will be next? The right answer will be thyroid receptor antibodies, okay, because that's the most specific test for Graves' disease. Ideally, here the next step would have been a radioactive iodine uptake testing. So that will be the ideal next test. Or even before that, first of all, we need to do a thyroid function test. So ideal next test would have been a TFT. And then once you confirm it's hyperthyroidism, it's radioactive iodine uptake studies, then next you're going to do antibody. This is the usual norm. But I don't think you had any option like TFT or radioactive iodine ablation. So technically, we are going to do thyroid receptor antibodies. There's no doubt about that. And there was another straightforward case of Pancoast tumor And I don't think that's a difficult one. There was some, like involvement of the sympathetic plexus and brachial plexus also. The neurovascular bundle was involved in that patient. So that was a straightforward Pancoast tumor. So I think many of you would have got that. And again, it's a repeat question, recurrently asked question, the parameters of the Q-SOFA score. Okay, the blood pressure, respiratory rate, and the Glasgow Coma Scale. So we know that already. And they have asked a question on GCS also, I suppose, if I'm not wrong. Okay. And question number 27. Yeah, there was a simple question. This was a repeat question from NEET PG 2021. It was a putty kidney image that was asked. So straightforward, it's a tuberculosis. And there was a question on a patient presenting with DIC, so many times asked again. So it's not going to be very tough at all. It's AML M3. Currently, we don't call AML M3 anymore. The right nomenclature for that will be acute promyelocytic leukemia, APML, or simply we can call it as APL. So the translocation that you're going to see is T1517. All right. And there was a question on neurolethyrism, you know, that the BOA is going to be involved and the treatment is going to be vitamin C for that. We know that. Burkitt's lymphoma, the classic translocation was given, the classic history, classic translocation. I think students would have definitely got that right. Okay. It's a T814 Burkitt's lymphoma with classic JAMAs, I guess, supposed to be. So there's an endemic Burkitt's that's going to be EB positive usually. And I think there was another question on CLL with classic smudge cells. Okay. In the peripheral smear, that's a straightforward giveaway. So that's basically going to be a chronic lymphocytic leukemia. I don't know this question, I'm not sure. So whether it is autoimmune hemolytic anemia or hereditary spherocytosis or not, I don't know. So there are two separate questions or only one question. I'm not sure about that. So if DCT was positive, look at the direct Coombs test. If it is positive, it must be an autoimmune hemolytic anemia. If DCT is going to be negative, then it's very likely to be hereditary spherocytosis, but definitely like the osmotic fragility would have been mentioned and something like that would have mentioned. Okay. So there was a question on optic tract lesion. So that caused like visual field defects. Typically, I think there was a right homonymous hemianopia. So that was the question that was asked. Like, I think the lesion was in the optic tract. That was another question. That's a straightforward and easy question. And yes, I think there was a lot of questions on HIVs. Lot of questions on HIVs. So one question, I think there was some ground glass opacities, which was suggestive of histoplasmosis. Another question on Kaposi sarcoma, there was lesions in the palate. Another question on disseminated molluscum contagiosum, where there have been multiple umbilicated papules throughout the face, I guess. So there are three questions on HIV basically. And STDs, there were some questions. And I think the easiest question that everyone recalled is the kits for the discharges. So that's something that we have discussed so many times, time and again and time and again and time and again. So that's something I'm not going to talk now. Yeah. And there was a question on gonorrhea. Okay. So, and the treatment of choice was ceftriaxone for that. And there was a pansystolic murmur image. I think there was an image that was similar to this. So right answer for that question is mitral regurgitation. And they asked the salicylate poisoning as well. I think so. And this is something that we have discussed in so many of our sessions. I think in Cerebellum channel, we have discussed more than 30 hours of medicine already. And in one of the sessions, we discussed clearly that for salicylate poisoning, alkalizing urine is very, very important because it's going to increase the elimination of aspirin, isn't it? So, or any salicylate for that matters. So this is one of the questions that was asked. So it was aspirin poisoning or salicylate poisoning. I think the DATRA poisoning one we discussed already. So that was intra document repeat, sorry for that. And there was another question on pneumoconiosis. I think students are telling that mesothelioma was mentioned. So I'm going with asbestosis. If mesothelioma was not mentioned, probably it could be silicosis. But because they are saying that mesothelioma was mentioned in the question, so it's very likely to be asbestosis. And it was a straightforward one. Like this is something that we tend to discuss every now and then. There was a question on Oprelvecin. So whatever maybe the history doesn't matter, but the question was, the answers were straightforward. So it's Oprelvecin. And there was a question on hypercalcemia in malignancy, which is a paraneoplastic syndrome, and the cancer that usually causes hypercalcemia of malignancy is the squamous cell cancer of the lung. So this is something that we have discussed so many times again. And I think there was a question on rheumatic heart disease. There was an Ashkoff nodule. I think it was a repeat question from 2021. So this was the question that was asked. I think there was a lot of other options that were like students confused, but I think it was clear-cut rheumatic heart disease, Ashkoff nodule. And what about like your alcohol? I think there was a question on Wernicke's encephalopathy. So it was a squamous cell cancer. It's not small cell. Like we have discussed so many times, time and again, that when you talk about PNS, most of the PNS will be small cell lung cancer. That one thing, hypercalcemia, is going to be from squamous cell cancer, not from small cell cancer. And I think there was some Wernicke's features like confusion, petechial hemorrhages, and I mean, something like that. Ataxia was there, ophthalmoplegia was there. So basically due to thiamine deficiency, and we are going to treat with thiamine. So treatment also is going to be thiamine, right? So whatever may be the case, that's straightforward one. And we know when to give thiamine, right? I don't know whether that point was asked or not. So whether thiamine should be given first or glucose should be given first. So we know that thiamine always first, then only glucose. So I don't know whether that's asked or not. So simply I'm saying. So another alcoholic, and he came with confabulations, some memory issues. So I think like it's a clear-cut Korsakoff amnestic syndrome. 2 questions were there. And there was a question on gout. I mean, with relatively normal uric acid, I suppose, with a classical picture. So treatment is going to be allopurinol. I don't know what's asked, but something related to gout was asked and something related to allopurinol. So there was some, that's what the students were telling, because the time was very limited and I couldn't compile the entire question. Probably I'll do it later on. But right now, I know that some question on gout and allopurinol was there. And they asked about like hyperkalemia. We have discussed so many times in a lot of our cerebellum sessions that there are only 2 causes for hyperkalemia. One is going to be drug interaction. Second is going to be CKD. Drug interaction in the sense we have to talk about ACE inhibitors, ARBs, and spironolactone. So these are the usual drugs that are going to cause hyperkalemia. So exactly, so that's what has been asked. Spironolactone is the one that's going to cause hyperkalemia. Gout already given allopurinol. Which one of the following can be given in acute? Yeah. Allopurinol need not be given in acute gout. It's a recurrent acute gout. Uricosuric was asked. Okay, we'll discuss about that later on, which will decrease the synthesis in gout. Okay, whatever may be the case, that's probably allopurinol. That's the right answer. So anyway, I think every one of you will be knowing that. So they asked about a man. I think it was a detailed history. I don't know. There is a dramatic history of this question where a man who was lying down somewhere was bit by someone. He couldn't notice what happened, but he was profusely bleeding. But technically, it is not cobra, it is viper, like, because it's a vascular toxic drug, right? So that's it. And there was a question on complete androgen insensitivity, I suppose. Like, it's straightforward one. I think we have discussed so many times in endocrine section. It was complete androgen insensitivity. And there was someone who was working for 20 years in a construction industry, handling vibration tools and pains, now presenting with white fingers. What could be the cause? I think this white fingers is basically due to Raynaud's phenomenon. So it is basically due to constant vibration. We know that continuous vibration can result in, Raynaud's. So basically this is a kind of a Raynaud's, like white fingers due to constant vibration. So that's it, guys. I think I've shown around like 50 to 53 questions. Like if you include this HIV 3 questions separately, so then it will be like around like 50 to 53 questions, which I've discussed so far. So these are the questions that I generally tend to discuss in my classes as well. So these are things that I used to discuss like in most of my sessions. And if you want, you can add one more question also, which my favorite topic is breast cancer. So I think ER positive breast cancers are going to have good prognosis, which is something that every one of us knows. And to be honest, like in our lectures, we'll be discussing on radiation oncology also. So the inverse square law has been asked. So that is also one topic from radiation oncology, straightforward topic from Harrison. I think that's it.
Yeah, Dilip sir. So we have, I have requested, if you can stop sharing the screen.
1 second, sir. Yeah, thank you.
Thank you very much. I requested our favorite and everybody's favorite, Dr. Goga Bhai, to come and say hello to everybody from the cricket field. You know, only cricket could have done this, that he is not starting the session. Goga Bhai.
Thank you, Apu, and hello, students. First of all the best for your results. सबका एग्जाम अच्छा ही हुआ होगा, I hope, and I wish के अच्छा ही रिजल्ट आएगा सबका. I'm very sorry, I was on the cricket field today and we won a Legends Trophy today. फाइनल मैच था, अभी जस्ट अभी मैच खत्म करके हम जीते हैं. ठीक है, तो ऑल द वेरी बेस्ट. मैं आपको फिर से मिलूंगा. आई विल टॉक टू यू मे बी टुमारो और डे आफ्टर टुमारो विद ऑल द क्वेश्चंस. हम डिटेल में डिस्कशन करेंगे एंड आई एम वेरी वेरी सॉरी कि मैं आपके साथ अभी डिस्कशन नहीं कर पा रहा हूँ. थैंक यू वेरी मच.
Thank you for the blessing, sir. Have a great time. Bye bye. Enjoy yourself.
Bye bye.
Dilip sir, I think that was the way to do it. One line at a time, and you finished it on time. And Dr. Gobind sir had already taken a session one day prior from which majority of the things came. I think he will just do a replica for the same. And now next we have Dr. Rana ma'am. And I have been closely seeing that ma'am has been organizing and making her content and lectures. And she has been putting a lot of work to make things easy for you. You know, this is what me and Dr. Dilip sir discussed when we were recording in the studio, that a clinician can give you a better perspective of how the questions will come, because majority of the questions will always come from the patients that you see. Common cases that you see, the ratio of the questions are going to be the same, right? And as the Pareto principle, we say 20-80, right? 20% of topics will give you 80% of questions. It is 20% of cases, all the diseases which the 80% of patients present. And so we have one more clinician here, Dr. Anna Chawla ma'am, who is into active practice. And so she's going to put her clinical knowledge into academics as a combination. And the way she's building up the content for all of you is phenomenal. And she is a team player. She thinks about the team as such. And that's how is the strength of Cerebellum. That is how when the teachers want to adjust together and build something which is greater than individual, that is when something comes out and which is great. You know, if you want to do good, improve your work. If you want to do great, make a great team. So I'll give on the channel to Rana ma'am. It's you and the students now. All the best, ma'am.
Thank you so much.
Bye-bye.
Thank you so much, sir. So hi, everybody. I am Dr. Rena, and so I was just busy compiling what the questions I got. I'll just share my screen with you. Just give me a second. Just give me a second. Yeah, so I hope this is visible. Okay, so we'll just quickly, I think some of them have been discussed, and we'll just take you through quickly the questions and the correct answers. So this was a direct question from last year's NEET PG. I think last year's NEET PG, it was actually almost the same question. This is a classical question on ectopic pregnancy. Remember, I always told in my revision series also, emergency obstetrics is very important. Question aana hi aana hai. Ectopic pregnancy, PPH, APH, all this will come. So this was ectopic pregnancy. On ultrasound, the sac size was given as the smudge, no cardiac activity, beta HCG was less than 5,000. What is the best management? So here it would be single dose methotrexate, because it fulfills all the criteria for medical management. Okay, then again, a direct repeat, parity index. Don't get confused. Twin delivery means para 1. Okay, doesn't matter whether it was twins or triplets. The pregnancy was 1, so it is para 1. Okay, the options I'm not sure, but I know the history was a twin delivery. If there's any clarifications or anything which I missed out, please add in the list also. Okay. Then there was a question on 36 plus 6, a multi with a previous normal delivery with a confirmed transverse lie. What is the next best step? Okay, so the next best step would be, many of you would think a cesarean section, but remember transverse lie and breech, if they're between 36 to 37 weeks, especially a multigravida, the next best step would be to offer her an external cephalic version. Okay, and that is to reduce the incidence of cesarean section. So the emphasis nowadays is reducing incidence of cesarean section. ECV would be the better option compared to elective LSCS. So remember, always look for the better option. I'm not saying LSCS is wrong. but what the examiners are looking for is the best option. Okay. Then 7 weeks pregnancy with hemoglobin at 9 grams. Okay, this is again a little controversial. Many of you are saying we will not give iron in the first trimester. Please remember, we're not talking about prophylaxis, we're talking about treatment. She's already anemic. Iron can be given, oral iron can be safely given in the first trimester. Okay, and you would want to start treatment. You won't leave her anemic in the first trimester waiting that her symptoms, gastritis and all would subside. You would start her on iron immediately. Okay, so the answer would be 8 to 10 weeks. You'd start her on iron. Okay. Somebody's asking methotrexate IV or oral. You will give parenteral methotrexate. Oral methotrexate is not given for ectopic pregnancy. Okay, so iron supplementation, please remember WHO guidelines, RCOG guidelines, everything, even clinical practice, we start them in the first trimester if they are diagnosed with anemia. Supplementation prophylaxis, if you're talking about, then it is at 14 weeks as per Anemia Mukt Bharat program. Prophylaxis is at 14 weeks. Treatment we start as soon as she is diagnosed to be anemic. Then there were several questions on cervical cancer. This is what I got. Cervical cancer involving the parametrium and extending to the lateral pelvic wall would be directly 3B. Treatment would be chemoradiation, mainly radiation supplemented with chemotherapy is the answer for anything above 2A2. Okay. Then a question came, 2 questions I think came on hysteroscopy. One was hysteroscopy can be used for, and I think the 4th option was tubal ligation. I'm not sure. But here the answer is Asherman syndrome. Okay, Asherman syndrome is the correct option because the cervical polyp would be visible. You don't need a hysteroscope to see it. A subserosal fibroid is on the outside of the uterus. A submucosal fibroid type 0 and type 1 could be approached by hysteroscopy. Asherman's is intrauterine adhesions, and we can cut the adhesions through the hysteroscope. Okay. Next question. Okay, again, a controversial question. Okay, so I got a lot of calls asking what is the correct answer. Women with multiple sexual characters. I'm not partners. I'm not sure what the exact question was. If there are any changes in this, please tell me. I think husband was truck driver or multiple sexual partners was what was given. With vaginal discharge, with cervical erosion on a speculum. So which kit would you give? So kit is again a favorite question. Now the confusion is between kit 1 and kit 2. Remember, kit 1 is for cervical discharge. Kit 2 is for vaginitis or vaginal discharge. Okay, now they've given vaginal discharge with a cervical lesion would mean that it is a cervical lesion, right? So here the more appropriate answer would be kit 1, the gray kit. I know many of you still are thinking, no, it's the green kit. But believe me, when I've said this, I have just gone through a lot of literature for this kind of question, unless my question is wrong. If they've mentioned a cervical lesion is there, that means the discharge is coming from the cervix. It's a cervicitis, which you will treat her for chlamydia, which is azithromycin, which is in kit 1. It is not kit 2 unless there is something which I'm missing in the question. So it's the gray kit, kit 1. Pregnancy with asthma, what should not be given? Again, I told you PPH comes. Active management of 3rd stage of labor comes. Okay. And the answer here would be to carboprost. Carboprost is contraindicated in asthma. Okay. Carboprost is 15-methyl analog of PGF2 alpha. It is contraindicated in asthma. Just give me a second. It's just seeing the YouTube. Any doubts if I'm missing? Okay, this is carboprost. Okay, there's a question on the partograph. I think it was a fully dilated cervix with a molding plus meconium. Anything else I'm missing? I'm not sure, but basically it was a clinical scenario of obstructed labor. Okay, the answer would be a emergency cesarean section, not a vacuum or a forceps. Remember, a 2nd stage arrest can, and this came in last year's paper also, that came as deep transverse arrest. So one question on labor, please expect. Okay, and this is definitely emergency LSCS. Obstruction means LSCS, no 2 ways about it. Even if she's fully dilated, you will do a cesarean section. You won't attempt a vaginal delivery even with instruments. Okay. Most common complication. Okay, there's another question again. I think there was more to this. They were given, the chest findings were given. But remember, in hysteroscopy, when we always look for fluid deficit. That means jitna fluid andar ja raha hai, utna fluid kitna bahar aa raha hai, we subtract and we calculate the fluid deficit. If you're giving normal saline, then we take the fluid deficit to be 2 to 2.5 liters, above which the patient may develop in water intoxication or electrolyte imbalance. And if you don't correct it, it leads on to pulmonary edema and congestive cardiac failure. So pulmonary edema is the correct option. Okay. You won't apply low forceps, Chirag, for obstructed labor. You will directly do a cesarean section. Okay. DIC will not present with fluid deficit. Fluid deficit will present with pulmonary edema, cardiac failure. Okay. Next question. There was an image of a Bartholin's abscess, I think. Okay, so Bartholin's abscess, this was a clinical scenario. This was very straightforward. I don't think anybody got this wrong. Okay, there's another question. Again, primary amenorrhea, high yield topic, very, very often asked. And 2 questions came this time from there. So primary amenorrhea with a suprapubic bulge and on doing a perrectal, a swelling felt on the entire length of the vagina. What does that mean? That means there's a hematocolpos. Hematocolpos, what can cause it? All the other options that were given were hematometra, I think, cervical agenesis, vaginal agenesis, all those will cause hematometra. Okay, this is hematocolpos, what you're feeling, and hematocolpos is caused by an imperforate hymen. Okay. Girl with no breast development, no pubic hair. This is another controversial question. Okay, so no breast development, it was very clear here. Okay, no secondary sexual characters at all, no uterus, no ovaries, no fallopian tubes, but she is looking like a girl. Okay, but bilateral inguinal masses were present, height was normal. This rules out Turner's. Okay, whenever you have secondary sexual characters present, absent, remember, think of gonadal dysgenesis. Okay, this is not androgen insensitivity syndrome. Why is it not? Because breasts are not development. Remember, in complete AIS, in partial AIS, I agree, maybe breast development may not be there, but in complete AIS, which was the option, you will not have breasts. Okay, so this so you will have breasts. In complete AIS, you will have good breast development. So this can't be complete AIS. This is actually Swyer syndrome. Swyer syndrome is 46XY gonadal dysgenesis. Okay, it presents phenotypically as a female. There is hypergonadotrophic hypogonadism. The ovaries are not there. Gonads are the male gonads, and that is why they are inguinal masses. And there is no secondary sexual character. So this is Swyer syndrome, hypergonadotrophic hypogonadism. This is not complete AIS. Please remember, complete AIS, breast will be very, very well developed. Okay. Next question. This was easy clinical scenario. 28 weeks, primary gravida with fetal parts not felt, with maternal respiratory distress, with fundal height, obviously much more than the period of gestation, fetal heart not heard easily. I think without even seeing the options, you should all know this is polyhydramnios. Okay. Then there was an image-based question on ovarian hyperstimulation syndrome. There was a scenario of a couple undergoing IVF. HMG was given. Okay, what is HMG? HMG is human menopausal gonadotropin, which can cause, so IVF, when you're giving ovarian hyperstimulation, they could be ovarian hyperstimulation syndrome. Again, a repeat question. Okay, another question on cervical cancer. I think we've already covered this. I've written it twice. Okay, then there's a question on, so HPV vaccine again comes. This was again an expected question. Mother died of cancer cervix. Daughter is 14 years old. What will you screen her for? Remember, cancer cervix doesn't have a genetic background. So there's no point doing your BRCA1 and all testing. You will give her HPV vaccine straight away. No doubts in this at all. Okay. Again, a question on infertility. Infertility is also a very commonly asked topic. 22-year-old female, no children after 6 months of cohabitation, BMI normal menstrual cycles. What will you do? Next step, remember, she's young. Everything looks all right. BMI is fine. She's only had 6 months of trying. Advise her to try another 6 months. You will just reassure her. There is no point doing investigations right now. Wait for another 6 months. The answer here is reassurance. Okay, then there was a question on supine hypotension syndrome. I didn't get the exact question, but this is also asked previously. Okay, so if anyone has the complete question, please let me know. Okay, so these were the questions. I think I've covered most of the ones on that were asked. If I have missed anything, please let me know. I think I've answered the controversies also. Please let me know if any doubts. So that is my session. Sir, over to you. Let me just see if there are any doubts coming in. Okay, that was it. Okay, any doubts? Fluid deficit cannot cause acute tubular necrosis. No, it will cause pulmonary edema. Okay, So I think that's it. Anybody else can take over from me? Apurv sir, Dr. Amrit. So Rashmi is asking, what are the inguinal masses? The inguinal masses in question are gonads. They're male gonads seen in Swire syndrome. It's 46XY, so male gonads will be there. They're not the ovaries. Okay. Dr. Amrit, I think you can take over.
In just a minute. Just give me a minute.
Yeah, sure.
Okay. So while my screen is getting loaded, I would just like to get a few opinions. How was the paper in general? You can write on the YouTube. I can see your comments. So let me know how you felt about the surgery questions. I don't believe they were the most difficult compared to the previous NEET PGs. I think they were quite manageable. Screen sharing on. Okay. So this is the recall that I got from the NEET PG from all my students, that there were a lot of basic questions, anatomy questions. What is key to note here is general surgery was asked a lot. So there were questions on neck swellings, swellings in front of the ear, those kind of topics. There were images on ulcers. So these kind of questions were asked. There were questions on anatomy of hernia. I had mentioned that hernia is going to come. You can never run away from it, right? So these were the kind of questions. Trauma surprisingly did not feature much. Please correct me if I'm wrong. If there were any questions on trauma, I could get a recall of only 2 questions, both of which were related to head trauma. Yeah, most people are saying average, moderate. Yeah, full of hernia. The recent reel that I had posted, I had told 3 important topics. One of them were hernia. Okay, so let us go one by one at the questions and you can correct. All right, you can correct me. So patient with varicose veins with skin changes, and they had mentioned the patient had eczema. What was the C stage? So skin changes with eczema was C4A. I'm sure most of you would have gotten this right. So that was skin changes, that was C4A. I had discussed this in the YouTube session on the cerebellum last week only. So they are not going to let you go away from varicose veins and CEAP, right? History was suggestive of Fournier's gangrene. So there was a big clinical case, some trauma in the perineum, he had pain, then there was gangrene. And they had asked what is the true statement, and the answer was caused by both mixed aerobic and anaerobic organisms. All right, there was one option where bilateral orchidectomy is done. That was not going to be the answer. You don't do orchidectomy, it's a fasciitis of the scrotum and it does not spread to the testes. The testes is squared. So there was a question on Fournier's, and how do you remember it? Remember, Fournier's is synergistic gangrene. So the synergy tells you that it is mixed. Aerobes and anaerobes work in synchrony or in synergy. Then there was another question. I believe this was an image. Okay, so I believe this was an image of something on the abdominal wall of gangrene, and they had asked you the incorrect statement. This was one of the tricky questions. Okay, this was one of the tricky questions that was asked. And yes, it was a Milanese gangrene, no doubt about it. And it can be caused by mixed organisms. Remember, Milanese gangrene is also synergistic, just like Fournier's. All right, it is also synergistic like Fournier's. So it is caused by mixed organisms, no doubt about it. These were the 2 options in which most of the students were confused. May require repeated debridement. HBOT is useful. Some students told me HBOT is not useful or not useful in reducing mortality. Irrespectively, the incorrect statement is going to be C. HBOT does have some benefit in Milanese gangrene, synergistic gangrene, or necrotizing fasciitis. Okay, it is beneficial and it is caused by mixed organisms and it may require repeated debridement. All this is given in Bailey. So the answer here is HBOT is not useful. Yeah, may require repeated debridement every 24 hours. This is correct. Okay, this is correct. Yeah, one question on debridement of black colored necrotic tissue. Yeah, there was another question where the answer was necrotizing fasciitis. Okay, the answer there was necrotizing fasciitis. I got that also. Then there were a few anatomy questions. So there was a question where there was a swelling above the pubic tubercle, and they were saying it's a direct inguinal hernia. Yeah, it was a direct inguinal hernia. And where is the defect? Now, technically, direct inguinal hernia is Hasselbalch triangle, but that was not there in the option, right? That was not there in the option. Urinary diversion should be the next step. No, urinary diversion is not necessary unless it is associated with urethral rupture. Yeah. So the answer here should be Hasselbalch triangle, but since it is not there, the next best answer is upturned part of inguinal ligament. Okay, this is the answer. Upturned part of inguinal ligament. So it's like this: the inguinal ligament turns, goes posteriorly, which will become the fascia transversalis, which has the deep ring and the superficial ring both. All right. So both are seen in fascia transversalis. But the best answer here would be upturned part of inguinal ligament. There was another image. Some of the students shared with me the image also, where they said there was an image showing the deep ring. And what is the defect? Again, the answer here will be fascia transversalis. So two questions, one on indirect hernia, one on direct hernia on simple anatomy. All right, on simple anatomy. If there is any change in the options, you can let me know. I am reading your questions on the YouTube. Okay, this question, in fact, I had discussed last week. Patient underwent bilateral inguinal hernia repair, and it was a laparoscopic repair. So they had mentioned this laparoscopic repair, and now he's having pain, chronic pain lasting more than 3 months. And they were talking about some nerve getting entangled in the tachus. Something of this kind was there, nerve getting entangled. And what is the answer? Patient also had pain in the thigh. Answer is lateral cutaneous nerve of thigh. Right, so no doubt here, this has been asked before. This is lateral cutaneous nerve of the thigh. That is the most commonly injured nerve in laparoscopic repair. They had mentioned about tachus. I know this for sure. Ilioinguinal is an open hernia. So ilioinguinal nerve would be the answer for open hernia. I think thigh and lower limb mean the same thing. Okay, it means the same thing. If whether they say thigh or lower limb, answer will be lateral cutaneous nerve. This, a lot of students are having controversy on that. There was an image. A lot of my students told me the images were very unclear and they could not make head or tail out of it, for which I will tell you, you don't need to see the image. You just need to know the basic principles. There was some history that was given. I don't know what the history was. Maybe the patient was diabetic, but they had given the image of an ulcer on the foot. Okay, so there was an image of an ulcer on the foot. Now, if the ulcer is on the sole, which is what most of my students told me, that there was an image of an ulcer on the sole of the foot, then the answer will be trophic ulcer. Okay, then the answer will be trophic ulcer or diabetic ulcer or neuropathic ulcer. If the ulcer is proximal or if it is on the toes, okay, if it's on the shin or on the toes with punched out margins, then it will be arterial or ischemic ulcer. Back partha, no diabetic history. Okay, if there is no diabetic history, and if there was a blackening, back partha ulcer. Okay, if there was blackish discoloration, then the answer would be arterial. Okay, if there was blackish discoloration. But if there were no skin changes, if it was a deep-seated ulcer on the sole, then the answer I would say is trophic ulcer. Okay, so my choice would be trophic ulcer. If you get the image, you can share with me. On the sole should be trophic weight-bearing areas where you will get pressure injuries. Then there was an image showing a fungating penile growth. So they had given an image of the penis and a mass on the penis, ulcerative, proliferative mass, cauliflower-like, and histopath was verrucous carcinoma. This again, tough question. The options were CO2 laser, 5FU, and partial penectomy. Remember, varicose ulcer, it has another name, something called Buschke-Lowenstein tumor. This is given in Bailey. Buschke-Lowenstein tumor. The answer for this is penectomy. This is for Bowen's disease. Okay, this is for Bowen's disease. Okay, podophyllin was also an option. Very good. Wonderful. So if podophyllin was on the option, it's not the answer. Even easier. So varicose carcinoma or Buschke-Lowenstein disease is partial penectomy. Okay, the ulcer was very red, deep, circular. Ulcer was on shoulder. No, I don't know of any this question. Venous ulcer nahi tha. No, it was a trophic or an arterial ulcer. It was not on the medial malleolus. Gator's area is going to be venous ulcer. Again, there was an image on CT brain, patient of head injury following alcoholic binge. Now I have two sets of responses I have received. Half the students told me it looked very much like an EDH. It looked like this. The infarct looked like this, the hemorrhage. If it looked like this, it is EDH. If you can't make out the image and you are only looking at history, and the history was of head injury 2 weeks back. Okay, if this is the history 2 weeks back and the image is unclear, then the answer will be SDH, because EDH of course is acute. So the history cannot be a trauma 2 weeks back. The history should be few hours back. So don't go at what the image is saying, whether it was concavo-convex or y-convex. An old history, SDH clearly, okay. So then it is SDH. Very good. All right. But please have a look at the history of what was given in the question. And don't jump the gun that it is EDH because it looked like an idli or a biconvex lesion. Again, even in the YouTube chat, there is a divided opinion. Yeah, 1 week old, 50-year-old, 2 weeks history, I would go for, again, SDH. No, SDH is most common after that. Ulcer washed border in back on anterior aspect of sole of foot. All right. Okay, let's move on. This was a very standard question. They had given you a clinical scenario and they had asked you the GCS score. This has been asked so many times in INI CET. I believe this was the response. Eye opening to pain was E2. Withdraws his limb to pain would be M4. Speaks inappropriate words would be V3. So answer was E2, V3, M4. Okay, E2, V3, M4. This has been asked a couple of times in INI CET, so no problem with this. This was an excellent question. All right, this was a wonderful question. They had given an image of a swelling below the ear. You could not make out what the swelling was, and they had said that the swelling shows mobility. This I have discussed in detail with 2 of my students just after the exam. So I know this is a legit question. Swelling showed mobility and variable consistency. Okay, variable consistency. Now, what does it mean? Even if you didn't see the image, you can get the answer. Jaw tumor will not be mobile. And sebaceous cyst or dermoid cyst will be soft. Pleomorphic adenoma will show variable consistency because it is pleomorphic. There are glandular areas, there are stromal areas. The gland part will be soft. The stromal part will be firm or hard. So depending on which component is predominant, there will be variable consistency. So answer here is pleomorphic adenoma. It's also called mixed salivary tumor. There was a similar question. Now this can change depending on what is the actual question. Okay, so there can be a little bit of variation on what was really given. So there is a swelling in front of the ear. The only history was given, and they had given the patient has a lot of pain. Okay, and they are given the history that patient has a lot of pain, and they had asked what is the cause of the pain. Yeah, then parotid tumor is the option. If it's not pleomorphic adenoma, means the same thing because it shows mobility. So in front of the ear or below the ear, a swelling which is causing excruciating pain. What is the cause of the pain? Now let me be clear. Auriculotemporal nerve or facial nerve compression will not cause excruciating pain. It will cause neuralgia. They will tell you something suggestive of neuralgia. Excruciating pain means there is a parotid abscess, and remember the pre-parotid fascia is an unyielding fascia. So the answer should be stretch of fascia. Again, if the words will change, the answer will change, but it will be stretch of fascia if it is giving excruciating pain, because the abscess will cause a stretch and that will cause the pain. So parotitis or parotid abscesses would give this kind of a history. Significant pain. Yeah, anatomical basis of pain. So below the ear, anatomical basis of pain, if it is a severe pain, should be stretch of fascia. Just like you get pain of hepatitis due to stretch of Glissen's capsule. Nerve compression, facial nerve compression is rarely the cause. It's a very deep-seated nerve. Within the parotid, facial nerve compression will cause facial palsy and not pain, right? It will not cause pain. Parotid lymph nodes or lymphadenopathy is usually painless, right? So that is going to be my answer. The basis of the question is the stretch of the deep fascia. Okay. This was a very standard question. I believe even the microbiome faculty would have covered this. There was an image. I don't know what the image was, at CT or ultrasound, but it showed it was a hydatid cyst. It was floating membrane sign or floating water lily sign. And the correct answer was it is a Echinococcus species. Right. So it is a Echinococcus species for the cause of hydatid cyst. This was an easy question. This is an important one. Okay, this is the kind of question which with good preparation you will be able to answer. So the question was based on chronic pancreatitis and they had given multiple stones. I'm not sure if they had given dilated duct or not, and patient had undergone a procedure. But it's simple. If there is a dilated duct with stones, okay, if there is a dilated duct with stones, this will require, means there is you require to drain the stones, you require to drain the duct, you will have to do a longitudinal PJ or a Puestos procedure. Okay, yeah, they are given 10 mm dilated duct, nothing like it. If they had given this 10 mm dilated duct, then nothing like it, it will be a longitudinal PJ. No two ways about it, no doubt over there. Bilateral palpable inguinal mass and Turner's. No, I'm not sure about that question. I have not gotten that recall. But the answer for this will be longitudinal PJ or Puesto, whichever was there in the option. I need little help with this question. Not students were unable to recall this. Please let me know if you have anything more in this question. So my student said that there was something that was ingested, whether it was acid or alkali, I don't know, and something about what is the first procedure you are going to do. So if you can help me with this question, I am not sure what exactly was asked here, but this is what I got in the recall, that something poisonous was ingested, probably acid, probably alkali, and what is the first procedure that is going to be done? Okay, NaOH ingestion. All right. Yeah, the answer for that is pancreaticojejunostomy. And what were the options? Are these the options? A patient also has dysphagia. Very good. And one option was stenting. Okay, that must be for the earlier question. Okay, so he consumed NaOH with dysphagia, which means they are trying to tell you there is an esophageal obstruction. Okay, that means there is an esophageal obstruction. What is the first thing you are going to do? The answer, according to me, should be feeding jejunostomy. But you also need to do a cervical esophagostomy if it is completely obstructed. If it's only dysphagia, then feeding jejunostomy is the answer. But if it is absolute obstruction, complete obstruction, you will also have to do a cervical esophagostomy. Both will have to be done. So there is something that is missing. You will not do feeding gastrostomy. You will not do anything, even a gastrojejunostomy, if this was there in the option. These are not going to be done. Please understand, in acute corrosive injuries, there will be esophageal inflammation, gastric inflammation. You don't want to touch them. So you don't want to do any esophageal surgery or gastric surgery. You're not going to do gastrojejunostomy for dysphagia. You're not going to do a feeding gastrostomy either. So answer should be between A and C. If a few words will change here and there, but in my opinion, the best answer should be feeding jejunostomy, followed by cervical esophagostomy. One of the two. Esophagojejunostomy is not going to be done primarily. That's not going to happen. If the option was esophagojejunostomy, even that is not going to be the answer. Because all these procedures, all definitive procedures are going to be done later after 8 to 12 weeks, where you will do a definitive procedure because you have to wait for the strictures to form. Okay, you have to wait for stricture to form. You don't know where the strictures are going to be in the esophagus, in the stomach, upper part, lower part. So in the acute setting, you are not going to do any reconstruction. So either esophagojejuno anastomosis, no, GJ, no. Feeding gastro, feeding jejuno. Answer will be feeding jejuno, even better. Shyam Kansal has given me 4 options. I believe with that it is perfect. Okay, feeding jejunostomy is the perfect answer in that case. You're not going to do esophagojejunal anastomosis in the emergency setting. Okay, this was a straightforward question. One question on mediastinal widening, different BP, aortic dissection. If that was asked, that I had discussed in my YouTube. Differentiation between upper and lower limb pressure. All right, stent to prevent strictures. You may put a stent, but till you don't know the extent of injury, there is no point in putting a stent. What if there is gastric stricture also? Then the esophageal stent is not going to help. Okay. History of aspirin ingestion, occasional alcohol consumption came with melena. I think there was also hematemesis in this question. So there was hematemesis also and melena and no hepatosplenomegaly. What is the answer? The best answer here is peptic ulcer bleed. Why? No, it's not Mallory stare. It is peptic ulcer bleed or gastric ulcer bleed. It's not going to be Mallory stare. Mallory stare, the intensity will be he will have vomiting, retching, hematemesis. Here they have given you no hepatosplenomegaly so that you rule out variceal bleed. Because variceal bleed means splenomegaly, means portal hypertension. Yeah, if they have also given pain, abdominal pain, nothing like it. So pain, hematemesis, melena, history of aspirin ingestion is going to be peptic ulcer bleed. All right. You need to help me with this recall also. I have spoken to many students what was exactly given and what was exactly asked. Okay. History of abdominal pain, vital stable, binge drinking. Yeah, it should be still peptic ulcer bleed or gastric ulcer bleed. A few words, if they change, then the answer will change. Right? So there was some question of this kind. Please help me over here. It said during abdominoperineal resection, what happens when the first artery is ligated? No, hepatosplenomegaly was not there. It wasn't there. 3 students told me that hepatosplenomegaly was not there. Okay, so what is the effect of the ligation of the first artery? And you can help me with the recall. I believe the recall was something like this. Sympathetic, parasympathetic, something. Now let me give you the rule. The rule is on what premise the question was based. This is not given in Bailey, but I'll tell you on what premise the question is based. So I have the inferior mesenteric artery here, and the inferior mesenteric artery will give some branches to the left colon, to the sigmoid, and then it will continue as the superior rectal artery to the rectum. All right. Now, what happens here is when I am doing ABR, if I ligate the IMA very close to the root or the superior rectal artery very close to the root, then it will damage the sympathetic plexus. Okay, so sympathetic is going to go. So parasympathetic options are gone. Sympathetic trunk will get damaged. That is the premise of the question. So what they had asked you was damage to sympathetics or sympathetic ganglia. Option C was not there. Okay, damage to sympathetic ganglia. I don't know then what was the other options. You can give me the recall if you know anything else. What will be the effect? The effect is going to be, please understand, sympathectomy or sympathetic damage leads to retrograde ejaculation, not impotence. Impotence or erectile dysfunction is a parasympathetic control. So answer will be sympathetic, affecting the bladder, and retrograde ejaculation. That is the premise of the question. Yeah, parasympathetic will cause erectile dysfunction, which is not a feature. Okay, which is not a feature. No, it's not importance. It will lead to retrograde ejaculation. When we do lumbar sympathectomies for peripheral vascular disease, the problem of lumbar sympathectomy, if I take both the lumbar trunks, is going to be retrograde ejaculation, not importance. Okay, sympathetic leads to retrograde ejaculation. Parasympathetic is required for erectile functioning. So parasympathetic loss will lead to erectile dysfunction. This was an easy question. There were some symptoms. There was sterile pyuria. Okay, so there was sterile pyuria that was given. And after sterile pyuria, there was an image of what I heard as putty kidney. So sterile pyuria, putty kidney, answer should be tuberculosis. Cutaneous anesthesia, impotence, premature ejaculation, bladder damage. Yeah. So it is going to be for that question. Cutaneous anesthesia is not going to feature. It's not necessary. What will feature is bladder damage and retrograde ejaculation. Here the answer is going to be tuberculosis. Okay, putty kidney was the option. I thought there was an image. The answer would be putty kidney. Wonderful. Then there were some other questions which you can say are overlapping between pathology, anatomy, and surgery. Straightforward questions. Like there was a question on AFP is a tumor marker for, the answer was hepatoma. Good prognosis for CA breast, the options were between ER positive, Ki67 positive, HER2 neu positive, something like that. Of course, ER positive is going to be good prognosis, no doubt about it. Then they had asked components of QSOFA, that is systolic blood pressure plus respiratory rate plus GCS. So these were some of the questions. I believe there was also one question on clonorchis is a risk factor for what, or worms in the biliary tree are a risk factor for what. The answer, if there was such a question, would have been cholangiocarcinoma, but I have not gotten a proper recall of that question. So for these questions, this is the recall. Now, if you ask me what to do next, don't worry about what has happened. You would have gotten too many questions recall by now. Don't start panicking. Just hear out how it has gone from whoever is left to discuss with you. And then take a break. Wait for the results to come. All right. If there are more questions of surgery, you can message me on Telegram so I can compile them together. All right. So now I would hand over to Dr. Janvi. She will discuss the questions on anesthesia. All right. So stay tuned for Dr. Janvi.
Dr. Amrit, fantastic session.
Thank you, sir.
Janvi, welcome.
Thank you, sir.
When the Home Minister comes, everybody gets up. The chair belongs to the Home Minister. There's no comparison. So I think, but I can see him at the back. That's the back support you have. You are luckiest right now. The students are in front of you, waiting for you. Enjoy yourself.
Thank you, sir. Okay, so students, as I had taken my ORR sessions, the original rapid revision sessions with Cerebellum, we had seen everything mostly image-based. It was a quick revision which had song and dance also, but mainly I had made you do an image-based revision. And as predicted, out of the 3 questions that came in anesthesia, 2 were based on images. Now, I have not put in any options for any of them because the answers were simple and straightforward. But before we start the recall, I want to tell you one story. When I was giving NEET PG exam, I remember coming back and getting irritated at all these recalls, but I sat through one of the recalls. And I remember at that time, all the people who were happy that they did well in the exam, we are getting all our recalls right. Of course, they got great seats. But there was also another batch of people, a bigger batch, who was quite unhappy because they thought that most of the answers have been wrong. And what happened? That day, everyone who was unhappy, after 3 months, I saw most of them in the central institutes like AIIMS and PGI. Why? Because the journey does not end here. The journey continues for the next 3 months to INI CET. So those who feel that maybe you all have not done well in the exam today, remember you could have a shot at a brighter future through INI CET and you could enter the central institutes. So with that, moving on to our first question. This was the maneuver that was given. This was recently asked in the INI CET exam also. And they had asked, what is the name of this maneuver? So it is nothing, it is simple. This hand over here is tilting the head. So it is called as head tilt. And this hand over here is lifting the chin. So this maneuver is called as head tilt chin lift maneuver. What is the use of this maneuver? This maneuver is used to open up any obstructed airway. So if you have a patient in whom there is no breathing, the tongue is falling backwards, patient is unconscious, you can open up the obstructed airway by lifting the chin and by tilting the head. And this we had discussed in the ORR session. Now, the second image that came was of this patient, and the options that were given with this were very, very different. So this was a little bit of a catch, little bit of a complicated question. Now, as I had discussed, this is called as the recovery position. And I had given you the reason why it is called recovery position. After our patient wakes up from anesthesia, when he's stable, we shift him in this lateral position, which is called as recovery position. Patient is stable, pulse is present, breathing is present. He is not completely awake. At this point in time, if the patient vomits or if there are any secretions in his mouth, it can go inside if you keep him supine. So while you're transferring him in that slightly sedated state to the recovery room, if the patient is supine, he can aspirate his secretions or vomit. But if the patient is put into a lateral position with one hand below his head and one leg on the other, any kind of secretion or vomit, it comes outside and does not get aspirated by the patient. So this is called as the recovery position. And the options were, you give this position when the pulse is present, breathing is absent, breathing is present, pulse is absent, all these confusing options. So this recovery position is given when the pulse is present and when the breathing is present. But the patient is not completely awake. The patient is slightly drowsy. The only thing you're trying to do is prevent any kind of vomitus or secretions from getting aspirated in this position. And the last image, again, we had discussed this in the ORRs as well as in the rapid revision that we had on YouTube a few days ago, was of this airway device. We had done a lot of airway devices one after the other. This one is used quite commonly. It is a disposable vortex tracheostomy tube. It is used whenever you do a tracheostomy front of neck access in any patient for long-term ventilation. It is single use, and this was the answer. So these were the 3 questions that were asked. Out of the 3, straightforward answers for 2, and 1 was slightly complicated, which you would have been able to rule it out. So I hope you guys got it correct. And of course, as I told you, if you've done well, if you're getting most of the answers correct, very good. We're extremely happy for you, and you will be starting off with your seat of choice. But for those who are feeling slightly stressed or depressed right now, remember, INI CET is still there to go. Thank you.
Janvi?
Yes, sir.
Can you stop sharing the screen? जानवी तुम ये स्टेप करके दिखाओ. नहीं हुआ तुमसे. चलो, बहुत बढ़िया. Amrit and Janvi, start recording. Go and enjoy yourself. Bye bye. Thank you very much.
Thank you.
Those who don't know, Janvi takes exact classes required and delivers with the questions that come in the exam. And now we have, on the same principle that I've been telling, clinical subjects, you need teachers who are active clinicians, because they will always get an extra edge. So our dear Dr. Praneeth is ready to discuss the ENT questions. And over to you, sir. You can just unmute, sir.
Right, sir?
Yeah, it's fantastic. Now we can see the screen as well. Thank you.
Yes. Okay. Thank you, sir. So, dear students, hope your exam has got well today. And here we are discussing a few questions, a quick revision of the questions today you have got. So, from ENT side till now, what all questions I have received? One question, main question was referred pain to the ear. Okay, the patient was having tonsillitis and the patient was also complaining of the pain in the ear. The reason is that it is mainly due to the referred pain by the glossopharyngeal nerve. You can see over here the glossopharyngeal nerve, which is supplying to the posterior 1/3 of the tongue. The same branch is supplying it to your ear also. Where exactly in the ear, you all know there is in the tympanic cavity in the middle ear. If you take your ear pinna, ear canal, and eardrum, you have your middle ear. Entire middle ear is lined by the mucosal lining that is supplied by your branches of your glossopharyngeal nerve, and the nerve branch that is supplying the mucosa of the middle ear is called as Jacobson's nerve exactly. Okay, hope you might have heard this name earlier. So this is the reason, the glossopharyngeal nerve is the reason for the referred pain in the ear whenever there is not only tonsillitis, even in cases of pharyngitis, both tonsillopharyngitis also, the patients will be complaining of the ear pain. But when on otoscopy, if you see the ear, it will be normal. And immediately you have to check the throat and you have to ask the patient whether they are having any throat pain, throat irritation, or also then they will say that yes, sir, from the last night or 2 days back, I'm having this one also. So that is the exact pathology there. So this is regarding the referred pain to the ear. And now coming to the next question, midline neck swelling moving along with tongue protrusion. This is exactly a thyroglossal duct cyst. You can see a thyroglossal. What exactly is this thyroglossal duct cyst is that? It is a cystic formation in the thyroglossal tract. What exactly is the thyroglossal tract? Thyroid. Whenever the thyroid gland is developing, okay, whenever the thyroid gland is developing, it forms from the tract from the thyroglossal tract. From the foramen cecum area here at the back of the tongue, there is a tract developing down, and after that, after birth, this tract gets disappeared. Only the thyroid will remain. Persistence of this tract even after birth will form a thyroglossal tract, and any cystic transformation will cause a thyroglossal cyst. That's why on protrusion of the tongue, from the foramen cecum area will also move forward. So your tract, the thyroglossal tract, will be pulled outward. So your swelling will also move upward. So this is the reason why the midline neck swelling, that is thyroglossal duct cyst, that moves with tongue protrusion, whereas your routine thyroid swelling does not move with the tongue protrusion. Only while deglutition, this thyroid swellings will move. That is the differentiating clinical point, examination point between your thyroid swelling as well as thyroglossal duct cyst. Okay, and also the famous MCQ, cyst trunk operation will be done for this thyroglossal duct cyst removal. Okay, because this thyroglossal tract will pass through the hyoid bone. Okay, so you have to split open the hyoid bone, and the tract will be passing through the hyoid bone, and you have to remove all the layers of all the tissue tract, the complete thyroglossal till the foramen cecum level above. You have to remove the entire tract. So that operation we call it as cyst trunk operation. And coming to the next MCQ, that is Krupp X-ray. So this was asked many times. This is called as steeple sign. We call it as, you can see due to the mucosal, this is supposed to be the normal airway, right? This is supposed, you can see a mucosal thickening, and the appearance itself is looking like a steeple over here, right? Okay, so why this mucosal thickening is happened is that the acute bacterial or viral infection of your respiratory tract, acute laryngotracheobronchitis, right above from the larynx, trachea, and bronchus, everything is involved here, and more compression, more narrowing will be seen in the subglottic area, and the below part will be wide open. So it will be appearing as a steeple. Okay, so this is the steeple. So steeple sign is seen in croup X-ray, okay, in croup or acute laryngotracheal bronchitis. And even another sign you have thumb sign that you see in case of acute epiglottitis. Only when your epiglottis is, if you take your nose, okay, and jaw, right? If you take your, this is your esophagus, and here you have your epiglottis, right? And down below you will be having your vocal cords here, right? Okay, and this will be ending into your lungs, right? Okay, this is a rough diagram, right? So on lateral X-ray, when you see your epiglottis is a thin leaf-like elastic cartilage, but whenever there is a supraglottis, upper respiratory tract infections, whenever there is edema of the epiglottis, the epiglottis will bulge like this. Now see, it is appearing as if a thumb is present on there. Okay, that's why it is called as thumb sign. This is seen in acute epiglottitis. Whereas if you come down below subglottic area, trachea and bronchus, so here you will see, but steeple sign will be seen on anteroposterior view, whereas your epiglottitis thumb sign will be seen on lateral view. Remember this point. And coming to the next MCQ. So one image was given. Most of the students were saying, exactly, I don't have any information exactly what exactly was asked, but nasopharyngeal picture was given, it seems. And you can see fossa of Rosenmuller was the answer, they say. So if you come to the nasopharynx, this is the endoscopic view of the nasopharynx you can see, and you can see the eustachian tube opening. So this is your eustachian tube, which connects your middle ear, anterior wall of the middle ear, and the inner end of it opens into your side of the lateral wall of the nasopharynx, right? So where it exactly opens in the nasopharynx, posteriorly it forms an elevation. This elevation is called as torus tubarius, and once there is a depression, definitely there will be a depression. Okay, once there is an elevation formed by this opening, definitely behind it there will be a depression forming. So that depression, you call this depression just behind this elevation, this is called as fossa of Rosenmuller. Okay, so this fossa of Rosenmuller is the most common clinical importance, is that it is most common site for nasopharyngeal carcinoma in elders. Any elderly patient presenting with ear one-sided unilateral deafness or hearing impairment, and on examination you see any serous fluid inside the middle ear, conductive type of hearing loss you are noticing, suspect any nasopharyngeal tumor, and immediately do a diagnostic nasal endoscopy, DNE, diagnostic nasal endoscopy. So this is in the first phase of the diagnostic nasal endoscopy. Once you see in this area, definitely you will be observing a growth. Okay, so nasopharyngeal carcinomas will be there. So this is regarding your fossa of Rosenmuller, right? And coming to the next, so bleed during tonsillectomy. So during tonsillectomy, arterial bleed will be mainly from facial branches. So that is tonsillar branch of the facial artery. So major part of the blood supply to the tonsil is from the facial artery. If venous drainage, venous bleed is asked, then you can go for this paratonsillar vein, which lies just below the loose areolar tissue plane. This loose areolar tissue plane is the plane of dissection during tonsillectomy. Okay, so if you go still much deeper, then you will land in trouble. There will be more bleed. Okay, so should be careful. And this is regarding your tonsillectomy bleed. And one more question: Rini negative for 256 and 512 Hz tuning folks, but Rini is positive for 1024. This you have to remember. If it is negative for just only 256, see, Rini negative means it is telling that the patient is having a conductive hearing loss, right? If it is 256 Hertz loss, at the only 256 Hertz frequency is lost, but 512 Hertz and 1024 are intact. Means when you are checking the patient with 512 Hertz tuning fork, if the Rini is positive, but only for 256 Hertz tuning fork, if the Rini is negative, then the loss will be very minimal at around 20 to 30. If it is both negative for both 256 and 512, but positive for 1000, that is normal for 1024, then it will be somewhere around 30 to 45. And if it is negative for all, then it should be 45 to 60. Okay, so this will be the in your exam, this was asked, it was negative for 256 and 512, but positive for 1024. So the answer will be approximately, the loss should be around 30 to 45 decibels, right? And also tracheostomy tube photo was given. So madam was also discussing about that. So these are the parts of the tracheostomy tube, and I hope already the madam has spoken about that. So Portex tracheostomy tube was shown in the picture, I think. And if you want to know the parts of the tracheostomy tube, so these are the flanges. So these help to fix the tracheostomy tube on the surface of the neck so that it won't dislocate. And this is the cuff, okay, and the main shaft of the tracheostomy tube, where exactly this is the conducting passage of the air. And you can see the pilot balloon here, and a trocar and obturator, okay, or obturator. See, the obturator will be fixed inside. So with the obturator, if you fix inside, it will be easy for you. Without obturator, it will be difficult to insert a tracheostomy tube. Remember that. And the inner cannula means some tubes will be having double lumen and some tubes will be of single lumen. If it is a double lumen, then definitely an inner cannula will be present. When inner cannula is present, so during routine maintenance of the tracheostomy tube, you need to take out the inner cannula, just clean it with antiseptic solution, and again you can reinsert it. This is very easy for home care people. And single lumen tracheostomy tube, you need to do the suctioning regularly. Okay, so these are few MCQs that I came across today, and still in further videos also will be updating regarding the next other MCQs will be getting. Sir, thank you.
Thank you, Dr. Praneeth. Thank you very much. It was fantastic. And now, you know, we have a person, Dr. Anand will be starting his pediatric session. And before he starts, I will request him to please say 2 lines for us. The students wants to hear your voice before you take them through a journey. And yeah,
good evening. I hope my voice is audible to everyone. Good evening, everyone. My name is Dr. Anand, and a wonderful evening to all the amazing people. Is my voice coming, sir? I hope my voice is audible to everyone.
Your voice is fantastic. And just a small request, student wants the question and the answer.
Right.
Right. But before that, everybody wants a beautiful, beautiful song from you before you start to pep up the evening. It's a Sunday evening. And after you, we will have a welcome of Dr. Atul, and then Pooja will be taking the last talk. So Anand sir, song from you.
Yes, sir. Actually, my heartbeat is already increasing so much. Definitely, I'll sing a beautiful song. So I'll start off with the session, and बीच में बहुत जल्दी मैं बहुत बढ़िया सा एक song सुना दूंगा सर, क्योंकि अभी सबकी धड़कनों के साथ मेरे दिल की धड़कन भी थोड़ी सी तेज हो रही है. So let's start this session. Good evening, everyone. Welcome to Pediatrics by Dr. Anand. A beautiful evening to all the amazing people. And this is session we're going to talk about is nothing but the pediatrics, our NEET 2023 recall questions. Please note these are the recall questions of the pediatrics paper. Short and sweet, up to the point we're going to talk about. I hope everyone, the exam was amazing. Good evening to all the beautiful people who are there live with us. And we always say, you know, that it is like do your best, and destiny will do the rest. So I hope you have done very fantastically. And let's just revise all the amazing questions possible to the point. The first question we had it over here, a newborn baby with hepatosplenomegaly with periventricular calcifications and hearing loss. A newborn baby with hepatospleno with periventricular calcification and hearing loss. So what is the best answer we have written? You can answer in the comment also. Hello Sachin, hello Raymond, hello Raman, Ravi, and all the great people. So periventricular calcification, the one beautiful answer which can come to my mind is nothing but cytomegalovirus. I hope you all have beautifully written about the CMV in the torch infection. We all know in the TORCH, the most common congenital infection in the torch is nothing but cytomegalovirus. And the main differentiation of the toxoplasmosis and the cytomegalovirus is nothing but in that the characteristic feature of the cytomegalovirus is periventricular calcifications. I'll repeat again. This was the question. This was the amazing question we had. A newborn baby with hepatospleno with periventricular calcification. As you can see this white dots, these are the periventricular calcifications seen only in cytomegalovirus, because in toxoplasmosis we all know we see intracranial diffuse calcification. Yes, that's true. Dr. Mas, we have this. We have another beautiful idea. Yes, intracranial diffuse white spots would be toxoplasmosis. Periventricular will be nothing but our cytomegalovirus. Okay, coming to the next question. Yes, Again, for all the question, I would like to thank one of my dear junior Priya Gupta. In a very short span of time, she had helped me in collecting the questions, and also one of my very dear junior Karan Vikram Singh. Two people have really helped me just now in the recall, rapid revisions. 2-year-old baby, very important, came with routine vaccination. What is the best answer? Yes, I'll be to the point and very happily will finish the question, whatever we are able to. This is my hospital vaccination card, and a very important. The question was 10-year-old. The question was 10-year-old baby with routine vaccination. What is the best vaccination to be done? Yes, Dr. Anush Yukta, you're very right. So 10-year-old, this is the 10-year-old baby, and it's written over here TT. TT is the vaccination which we give at 10 years of life. So to the point, the answer will be nothing but TT vaccination, that you should know. Okay. Yes, coming to the next question, very importantly, yes, the Dr. Priya, she had told me there was a question on the triad of torch. There was a question she was asking: a baby is having congenital heart disease, a baby is having congenital heart disease, a baby is having cataract, and a baby is having deafness. So what is the best answer we can think on this? We can ask in the comment section. That's true. So Raman says image quality were as good as a 3D movies. Okay, that's great. Okay, so this, I hope I'll be to the point. So this, we all know that the triad of the torch infection. In the torch, if I talk about congenital rubella, the triad we have is Staphylococcus, congenital heart disease, cataract, and deafness, which is the most common congenital heart in a congenital rubella syndrome. We have Mani Peza who says PDA was given. Yes, the most common congenital heart in congenital rubella syndrome is patent ductus arteriosus, and cataract and deafness. This is the triad of the congenital rubella syndrome. The most common manifestation being the deafness, and the most common congenital heart in congenital rubella syndrome is nothing but patent ductus arteriosus. Very good. Okay, this was the point of congenital. This one, yes, exactly, congenital rubella. And congenital rubella syndrome is also known as Greg's triad. It's also known as Greg's triad. That's very true. Next question was this. I'll be sharing the picture, the recall one, and I'll be telling to the point, short and sweet, so that we can have a beautiful life ever after. And also rank 1 was born to be yours. So what is this, dude? This was the question. Yes, Karan was saying this is a surgery question, could be a pediatric question. Water lily sign. So where do you see water lily sign? Yes, you all know that water lily sign is seen in only one condition, hydrated liver cyst. Water lily sign. Yes, Sanya, this is the one line only. So water lily sign, as we all know, ultrasonographically you see in a case of hydrated liver cyst. Perfect answer. Very good. Next question. This was the image, like this was not the image, this was a recall question. So this could be one image, very importantly, of our what you called in the pediatrics paper. It's a medicine question as well as pediatrics question. So what is this? So this beautiful ring at the descent membrane of the cornea, we all can appreciate this, our KF ring. Where do you see KF ring? We all know KF ring is nothing but the Kaiser-Fleischer ring. So Kaiser-Fleischer ring we see in a case of Wilson disease, that we all know. The question was regarding the levels. So I hope you know that what happens to the serum copper levels. Does it increase or decrease? So we all know the only mnemonic is copper everywhere. Copper everywhere. Yes, exactly. Serum copper levels in a case of Wilson increases. Even if I talk about the hepatic copper content, what happens in a case of hepatic copper content? Hepatic copper content also in a case of Wilson increases. What happened to the what happens to the urinary copper levels? Urinary copper levels also increases in the case of Wilson. The to the point exam answer we all know regarding the serum ceruloplasmin level. So serum ceruloplasmin levels we all know in a case of Wilson disease it decreases. So that was the question. The gold standard investigation of choice in a case of Wilson disease will be liver biopsy. If I talk about the gold standard investigation of choice, the answer is liver biopsy. If I talk about the level, there is a decrease in the serum ceruloplasmin levels in a case of Wilson disease. Now, next question. This was again, I'll be telling to question and image and to the point answer, not diverting anywhere out of it. Exactly. So yes, bowing of legs. So this, my doggy Oscar also can answer very nicely. Bowing of legs and widening of wrist. We see in a case of vitamin D deficiency case, this was the direct answer. Which vitamin deficiency you can think of? If I talk about ADEK, bowing of legs and widening of wrist, we all know we see in a case of vitamin D deficiency, nothing but in a case of rickets. So to the point, the question was there exactly. So perfect answer. That's one. Yes. So that Dr. Raman, you're right. Urinary copper increases, hepatic copper increases, everything increases in a case of Wilson except the serum ceruloplasmin levels. Okay. Yes, exactly. I hope you guys are doing amazing. Life is beautiful. Okay. अच्छे से अब तो बस ऐश करनी है, बहुत अच्छा होगा life में आगे. So bowing of legs and whitening of wrists is seen in vitamin D deficiency, and vitamin D deficiency you see in a case of rickets. Next question, to the point. Again, yes. Again, I would like to thank Dr. Priya Gupta for this beautiful question. She told this was a recall. A baby with blue cornea, lacrimation, and photophobia. A baby with yes, exactly. A baby with blue cornea, lacrimation, and photophobia. What is the best answer you can think of? Dr. Raman Bansal, the gold standard investigation of choice in a case of Wilson is liver biopsy. Baby with blue cornea, lacrimation, and photophobia. Yes, that's very nice. So exactly, the answer for this question will be congenital glaucoma. We all know that. A baby with blue cornea, lacrimation, and photophobia, newborn baby with a picture like this looks like a case of congenital glaucoma. This was again to the point I'll be telling about. This was the question for pediatrics. Next very question. Yes, this is a ENT question. This is a medicine question. This is a pediatrics question. This question has come so many times. So it's good this question has come again. So we all know this beautiful question is nothing but steeple sign. Steeple sign is nothing but the laryngeal spasm. I can say there's a spasm. This black is nothing but my larynx. So there's a laryngeal spasm, nothing but a steeple sign you see in a case of croup. Which is the most commonest cause of croup? Can you answer in the comment? I hope you know that. So the most commonest cause of croup is para-influenza virus. We all know. Yes, the most commonest cause of croup is para-influenza virus. This is a steeple sign. Steeple sign you see in a case of croup, and that's what the treatment you give steroids and nebulization, dexamethasone and adrenaline nebulization. As we all know, two signs they always ask in exam. So this was the X-ray sign, steeple sign you see in croup. Okay, and this slide should not go unnoticed without touching the croup and acute epiglottitis. So we all know that thumb sign you see in a case of acute epiglottitis and steeple sign you see in a case of croup. In a case of thumb sign in acute epiglottitis, you give antibiotics, cephalosporin 3rd generation, whereas antibiotics have no role. Antibiotics have no role in a case of croup. I hope you know that. In croup, you give steroids. Okay. In acute epiglottitis, you give antibiotics. They always ask this question. There is no doubt about it. Another very beautiful question we had on the vitamin K. Vitamin K dependent clotting factors. Yes. Hi, Dr. Monty, Pallavi, Surya, Priya Gupta. Very nice, Priya Gupta. I'm really happy you got a rank. Like, I think you got a rank. I just feel that you already got a rank. So very nicely you all are answering. So vitamin K dependent clotting factors. She told me that sir, is directly a question aaya tha. Yes, vitamin K dependent clotting factors, we all know that factor 2, 7, 9, 10. There was a direct question on that. Vitamin K dependent clotting factors, factor 2, factor 7, factor 9, and factor 10. We all know that. Okay, perfect. Next question. Why do you get bleeding manifestations and ecchymosis in a case of vitamin C deficiency? Why do you get this? Again, Priya told me this was like that's what. Why do you get hota kyun hai? Vitamin C deficiency. I hope you know that we all get subperiosteal hemorrhages, ecchymosis, bleeding manifestations. Like, what is the main problem? The main problem this was the FMG question again, collagen formation. The FMG question 2023 recall was defective collagen formation is associated with which vitamin? The answer was vitamin C. Now here the question is, in vitamin, they told that vitamin C deficiency, you see ecchymosis, you see bleeding manifestations. Why do you see? So because of collagen formation. Okay, collagen formation is connected with the vitamin C. Chloride levels is done in which disease? Very clear-cut question, very beautiful clear-cut medicine as well as pediatrics question. So where do you see chloride levels? Where do you, I hope you know that. Yes, Dr. Pallavi, Priya, Sharda, Amit, that's right. So sweat chloride levels. We all know beautifully in a case of cystic fibrosis. Sweat chloride levels we do in a case of cystic fibrosis. Yeah, that's very right. Very beautiful. So cystic fibrosis is the right answer. Sweat chloride levels. And what is the hallmark of cystic fibrosis? The hallmark is this only. The hallmark of cystic fibrosis is nothing but elevated sweat chloride levels more than 60 millicurrents per liter. I'll be telling to the point, elevated sweat chloride levels more than 60 millicurrents per liter is the hallmark for cystic fibrosis. And the question for this year was chloride levels is done for which disease? The answer is cystic fibrosis. Remember that. Okay. So life is beautiful. Life is amazing. Okay. A quick motivating quote which says no one is you and that is your superpower. No one is you. Exam ho gaya. you were born to rock, you were a superstar, and rank is this time is definitely yours. So no one is you, and that is your superpower, dude. The next question we had is this very beautiful, simple question. My friends told me darkening of urine on standing. There was one student who told me it was a question on darkening on urine on standing, and there was a one student who told it was written that black urine in infants is seen in which condition. So black urine in infant is seen in which condition, or darkening of urine on standing? Exactly. So what do you think, Dr. Paisa, Dr. Shraddha, Raman, very good, Rohit, Ravi, and Faraz? That's true. So darkening of urine on standing, a beautiful picture. Again, this was the urine on darkening, it became black. So the clear-cut answer is L-captonuria. L-captonuria, again, from inborn errors of metabolism, there were multiple questions. From vitamins, there were multiple questions. So, and last 3 year question papers were really very important. So what is the triad of L-captonuria? So beautiful. Yes, Dr. Sachin, Raman Bansal, Neeraj, and our Priya Gupta. That's right. So L-captonuria, we all know it's very easy. The triad is that's only darkening of urine on standing, ochronotic arthritis, ochronotic pigmentation, and darkening of urine on standing. And the last year question was, what was the enzyme deficient in L-captonuria? The answer was homogentisic acid oxidase. And this year question indirectly came again, a baby having darkening of urine on standing. The answer is nothing but L-captonuria. Okay, this was again a vitamins. They had multiple questions. I'll be telling to the point. That's right. Hanji, Dr. Mani Paisa, this question is there. Aane wala hai. So I'll tell you. Yes, it is right. So a baby with a perioral and a perivaginal rash with delayed wound healing. Quick and clear-cut question. I'll be telling to the point. Perioral, perivaginal, delayed wound healing. Perioral and perivaginal. So this 1000 times we have covered this perioral and perivaginal is because of zinc deficiency. There's an entity known as acrodermatitis enteropathica, which is nothing but acro means periphery and dermatitis means rash. So indirectly the examiner is asking the baby is having perioral and perivaginal rash plus delayed wound healing. Zinc really helps very nicely in the wound healing. So that's why zinc would be the best answer for this question. Okay. So next one, the next question we have it over here is, yes, this was a good question. It was a good classic question. A baby who is dehydrated with sugar 550. Now this is a good question. A baby with having dehydration with hyperglycemia. In the baby's urine, ketones were positive and the baby was having acidotic breath. So first of all, what do you think of? We all know that, yes, we think of diabetic ketoacidosis. DK sounds a very good option. The patient has hyperglycemia, the patient has urine for ketones positive, and dehydration is an associated factor for nothing but diabetic ketoacidosis. Now the question very importantly, okay, yes, Dr. Javed, okay, thank you so much, Dr. Javed. So the question, like I'll be telling the approach to DK, just the answer basically if I'll be telling about. So we all know polyuria, polydipsia, and all those hyperglycemia and acidotic breath or urine for ketone positive is classical for DK. Now the question will be like the answer was, what will you do? So I'm just telling you that the flow chart which we follow in our hospital, whenever a DK is confirmed, the diagnosis of diabetic ketoacidosis is confirmed. Number one, it depends whether the patient is in shock or the patient is not in shock. In your option, the patient was having dehydration, the patient was into shock, right? I'll repeat again. Once the question was regarding DK. DK is nothing but you have this polyuria, RBC very high, and the RBS very high, and urine for ketones positive. In that case, number one is DK with shock or DK without shock. If it was DK with shock, our clear-cut protocol says you give bolus at the rate of 10 to 20 ml per kg. Now, this was the exam question. Please pay attention, very important. You give the bolus or you manage the shock then and there only, and also you start the continuous insulin infusion at the rate of 0.1 units per kg per hour, started 1 to 2 hours after the fluid treatment has been initiated. This is one point. The exact options I don't know because many were saying many things, but one definitely point I can take home message for this question is DK with shock. The protocol says you give the bolus at the rate of 10 to 20 ml per kg per kg stat, followed by insulin infusion. You give the bolus and start off with the insulin infusion. With you calculate the fluid requirement. This is what you do. Okay. Next question, very importantly. Now this again was clear cut Priya's only point. Sir, a question tha ke which one is correct? A question tha ke which one is correct? Yes, Dr. Mani Paisa, I came back to you again. Very nice. So which one is correct? So, okay. If I say option number 2, height 25th centile, this is not correct. Weight 75th centile, this is not correct. Anything, the normal thing should always fall in 50th centile. Height, weight, whatever you say should be in a beautiful 50th centile graph. So this is not correct, my dear. This is not correct. Okay. baby height 25 centimeter increase in the 1 year. Yes, this we have done multiple times in the growth and development chapter. A newborn's baby normal length is 50 centimeter. At 1 year of life, the baby's length is 75 centimeter. From the birth to 1 year, there is actually an increment of 25 centimeter. So this line is very well true, that baby height 25 centimeter increase in the 1 year of life. This is very well true. The last option we have is baby ka weight approximately 300 gram increase hota hai per month. This is what my junior told me. So baby ka weight approximately 300 gram increase hota hai per month. This is not the right answer or point, because we have done over here in our growth and development chapter 400 grams every month till 1 year. Till from 3 months to 1 year of life, the weight increases by 400 grams every month till 1 year. That is why option number A is the best answer. Done. Last two questions: diarrhea, dementia, dermatitis, death. Very easy, to the point. What have you written? I hope you have written something nice. Bharat, Manipesa, Aditya, Yukta, Rudraksh, and Raman Bansal. That's right. Diarrhea, dementia, dermatitis, death is nothing but, to the point, it happens in niacin deficiency. Like vitamin B3 is nothing but niacin. Niacin deficiency causes this problem: diarrhea, dementia, dermatitis, death. And we all know that, very importantly. Yes, इसमें staple diet क्या होता है? So we all know that stable diet क्या होता है? Staple diet, someone having stable diet of maize, because maize or bhutta, so maize is having deficiency in vitamin B3, and vitamin B3 deficiency nothing but cause diarrhea, dementia, dermatitis, death. So, and the patient is having rashes like this. So that's it. Very, very important. Yes, perfect. Okay, so that finishes this part, and thank you so much everyone for this participation. It was a quick rounds for of the rapid revision, and I would say the question which recall question specifically to the point. मुझे exact question तो नहीं पता, पर ये recall थे. And before leaving, we always say whatever you do, always give your 100% unless you're donating blood. So thank you so much everyone. Special thanks to Dr. Karan, Dr. Priya. They helped me a lot for today's recall. Thank you, sir. Over to you, sir and ma'am. I hope my voice is coming. Hello, is my voice coming? Please let me know. So this was
it's so beautiful, and we are waiting for the song.
Sir, okay. Okay, the quick song will be very nice. दिल की डाली पे कलियां सी खिलने लगी, जब निगाहें निगाहों से मिलने लगी, एक दिन जिंदगी इतनी होगी हंसी, झूमता आसमां गाएगी ये ज़मीं, मैंने सोचा न था. Thank you, sir. Thank you. You are my favorite, sir. Dr. Apur Mehra, sir.
The thoughts and the love is same. Fantastic session, Anand.
Thank you, sir. Thank you so much.
It is nice to see you being loved so much across. The biggest respect that you get in the earning a teacher gets is the love of the students, and that is what you're getting. You are at your peak. Keep rising and shining. The next is my MAMC batchmate and a phenomenal teacher and a human being, Dr. Atul Gupta. He's just going to come and say hello to all of you, and I'm sure that you will love his teachings in Cerebellum. And right now, I just requested him to wish students all the best and just share his thoughts about forensic part of NEET PG exam. Dr. Atul.
So, hi everyone, and what a right time to join in. I just happened to listen this beautiful song from Dr. Anand. And so I was actually going through, I was receiving the questions, but I'm yet to receive all the questions. I believe most of these questions were something which we normally teach in our class. I don't see any question which was out of context. And I hope that most of you would have got that right. And as and when I get the full content of the question along with the choices, I will be getting back to you and discussing the same. I hope all of you were able to hit the right answers. And again, wish you very, very all the best. Thank you.
Thank you very much, Dr. Atul, for joining at request, and see you with the lectures in Cerebellum very soon. And now we have the last teacher, and she is one of the most passionate teachers you will come across. And it gives me an honor, a pleasure to welcome Dr. Pooja to teach physiology. And physiology on an evening, which is a weekend after the NEET PG, people are ready to change the physiology and do many things now. The evening is setting, and I think Pooja, over to you, and then I'll conclude the session.
Thank you, sir. Thank you so much. I hope I'm audible and visible, guys. I just need permission to share my screen, and then we'll discuss it.
You can do that now.
Hi, guys. All right. Guys, please let me know if I'm audible and visible to you. Yes, in the YouTube. And how are you feeling? I'm sure you are, that anxiety must be gone, right? Yes, am I audible and visible? Good to go. All right, thank you, Bablu Singh. Till I get more replies, I have one shairi for you, if you guys permit me, right? So let's start with the first question. Recall chal raha tha to aa gaya, koi baat nahi. Let's go. Let's start with the questions, right? Okay, Bablu Singh. So there we go. Lakh daldal ho, par paav jamaye rakhna. Lakh daldal ho, par paav jamaye rakhna. हाथ अभी खाली सही पर नजर उठाए रखना. कौन कहता है छन्नी में पानी नहीं रुकता? कौन कहता है छन्नी में पानी नहीं रुकता? बस बर्फ बनने तक विश्वास बनाए रखना. So with that thought, let's start with the recall questions. All right, thank you very much, Danish. So the first question was showing something like this, right? One carrier protein was shown, and then we had one carrier protein was shown, and on the one side there was a high concentration of substances, and then on the other side there was low concentration of substances, and no energy was utilized. So that means, first thing first, it is the passive. It is the passive type of transport, and we know if we are using the proteins, that means it must be the facilitated transport, right? So we divide the transport into active and passive. Yes, please. हमें तो लूट लिया physiology. My God. All right, active and passive. Active may we use energy, right? And passive may we do not require energy. Active may we do have primary, secondary, and vesicular transport. In the passive, we do have two things. That is, first is the osmosis and diffusion. In the diffusion and osmosis, right? Osmosis is of water, diffusion of substances. In the diffusion, we divide into two, the simple and facilitated. In the simple diffusion, we do not require anything. It will go by simply through the membrane, like lipids and the gases, right? But in the facilitated, we require the carrier protein, right? And the carrier protein will have configurational change, and with that, without using the energy, we're going to transport the substances, right? Okay, aaj nahi pada na. All right. So carrier protein, and it was the facilitated diffusion. Then next question came as, okay, I'll make it like this. Okay, the next question came as the action potential, cardiac action potential, and it was shown like something like this. These were the options. We know this is the 0th phase. I always tell you, do not get confused in the 0 phase, right? In the 0 phase, it is because of the sodium channel, not the phase 1. It was not the phase 1. Phase 2, calcium channel opening. Phase 2, calcium channel opening and plateau. That's true. Phase 3, sodium channel closes and potassium open. No, guys, over here the calcium will close and the potassium is still remain open, right? Carrier protein was the option. All right, fine. So carrier protein, that means the facilitated. Fine. Anything passing through the membrane? All right. Okay, so this is wrong. The phase 4, sodium, potassium, ATPase activity. Now remember, it was something related to it that it increases because of that. It is not because of that. It is rather because of the closure of the potassium channel. Let's move on to the next thing. That is the action potential of neuron was shown, and some A, B, C, D option was given. Like suppose this is A, this is B. Let's say over here somewhere it is C, right? Then the D, and let's say E. Then they showed the phase And we discussed that in the recall question also, PYQ session. I'm happy that at least 2 or 3 questions came from the recall question, right? In the kidney also inulin, we refractory period. Yeah, that is what we are discussing, Raman. Over here, the phase threshold was shown, but they have given this phase from B to C. Let's say that was the threshold. This is not the threshold. They have given the depolarization and showed as a threshold, so that was wrong. Let's say the phase. This said that from B to D, it was the ARP. That was the correct answer. RRP, they have shown, let's say the E option was shown as the RRP over here. So that was wrong. The depolarization they asked, because of the depolarization, let's say they asked about B to C, it is because of the opening of potassium channel. The potassium channel, as soon as it opens, except the ear, everywhere it is going to be the repolarization and not the depolarization. So answer over here, as per I got the question, it was the ARP. Okay. Okay, now about the hyperkalemia, we are going to come up onto that. Mass dot. Okay, so first thing first, if I got to know that if the hyperkalemia was the case, then the scenario going to be different. But students told me that it was shown as the potassium level was given as 5.5 milliequivalent per liter, and we are not going to call it as hyperkalemia. Understand this. The injury, if it is given as a severe injury, why? Because it is even mild hyperkalemia is there, the sodium potassium pump will compensate the changes in the RMP. Now, if it was clearly written as hyperkalemia, then the answer will change. If it was given in the exam question, that is 5.5, then it will remain unchanged, because whatever in the mild hyperkalemia, it won't change much. Okay, if the hyperkalemia is there, then definitely more potassium will not be able to go out, and potassium accumulation is there, and it is going to go towards more positive. Suppose if it was, I'm giving you both the things, as soon as we are going to get more clarity on the questions, then we are going to move on to it. If it is hyperkalemia, then the answer, it is clearly should be mentioned in the question. Then the answer will be more positive. Okay, more positive. And if less negative was also there or not, I do not know this option, because these two are exactly the same. So I think the answer is going to be remain unchanged, 5.5 only. Then if it is 5.5, remember the sodium potassium pump ATP activity, it is going to be slightly more, and it will balances the RMP, because we want to maintain the homeostasis, right? In the mild injury, we do have injuries day in, day out, right? We are not going to change the RMP of the cells. Then the question was on next question, money paisa. Okay, mass drop. I think both were if both, how can both be mentioned? If both will be mentioned, I mean the options, then you have to go with unchanged, right? Okay, the spirometry was shown and the FRC was asked, like suppose it was not written like this, A, B, C, D was not written. So over here, this is going to be the tidal volume, the extra amount of air is going to be IRV, and they asked about this value, that is the ERV plus RV, and that is going to be the FRC, okay, functional residual capacity. I hope this question came. There was one line. Okay, right. Sahi baat, mission NEET PG. Right. I hope your mission get accomplished. Okay. Decreased surfactant cyanosis. There was a case of RDS, respiratory distress syndrome. We know that as soon as these surfactants are going to be decreased, they ask, first of all, what type of surfactant or which one of the following, like that. So if we are talking about surfactant, definitely it is going to be the DPPC, that is nothing but dipalmitoid phosphatidylcholine, not the ethanolamine. Okay, so it is like a foolish thing to mark that without reading all the options, right? Zainab ma'am already have told you that you have to read all the options, right? So over here, the lecithin was the most appropriate answer. They asked the surfactant because the sphingomyelin is also right, but understand when we do LS ratio, the sphingomyelin contributes very less and it is minor surfactant. On the other hand, the 70% is contributed, around 65 to 70% is contributed by DPPC. All right, let's move on to the next question. Again, the case of RDS was there and they asked about the compliance and surface tension, isn't it? Bablu, yes. What B and C, please let me know the questions also, right? Okay, so surfactant is decreased. What the surfactant is going to do, I always tell you, the compliance is outward force, that means stretchability or distensibility, right? On the other hand, the surface tension is inward force. And when we talk about the surfactant help us to reduce the surface tension, right? So that means if we say that surfactant, when we talk about, that it is going to help us to increase the compliance. If the surfactant is decreased, that means the compliance is decreased and the inward force is going to increase, right? All right. Increase in tension and compliance. Now the tension should have reduced, right? All right. Your tension I'm talking about. And this question, I'm 100% sure if you attend the PYQ that you are correcting it rightly, because we have discussed the same question and I added the same slide. I'm very happy that this question came. I don't know. Right. We discussed that if, I don't know what type of graph it was, but it is somewhat related to inulin. And we discussed that the inulin is the substance which is only get filters and it will not be changed via secretion or the reabsorption, right? Even some people told me the graph was like something like this, that from the PCT it is going towards the CD, right? And the concentration, suppose one of the concentration of filtration is increasing and one is decreasing, but they ask about the inulin itself. So be the graph, be that the graph, this one or this one, we know that if it is unchanged, that means it is inulin, right? There were 4 options, but I did not get the 4 options. You helped me out to make the 4 options, and we are going to make it, a nice recall questions, right? So resting tremors, rigidity, hypokinesia, these kind of symptoms were given, and this is the classical case of Parkinsonism. And they were asking the parts, which part of the CNS will be affected, and this is definitely going to be the basal ganglia. Okay, the Sucheta, even if bicarbonate is there, bache, still bicarbonate is going to get reabsorbed, right? So it cannot be a simple straight line, right? Even if the bicarb is there, the bicarbonate is going to be decreased because almost all the bicarb is going to get reabsorbed. Over almost 90 to 95% of the bicarb is going to get reabsorbed in the PCT itself, right? We know that. All right. Fine. So one thing that I wanted to tell you, that success doesn't come from what you do occasionally. It is the consistent efforts, right? Next, low in insulin to glucagon ratio. That means the insulin, the numerator must be low and the glucagon must be high, and insulin is low. That means the glucose levels are less, and that means somewhere the options must be like the, yes, basal ganglia is the answer. Basal ganglia is the answer. All right. Glucose is going to occur in the PCT, maximum reabsorption, that is almost 100%, because it cannot be reabsorbed later on. Ritvish, yes. Hippocampus, what is the role of hippocampus, bache? It converts the this STM, that is short-term memory, to long-term memory, right? And the memory loss per se, rigidity cannot be seen in the hippocampus region, right? It is the basal ganglia. Yes, Shraddha, you are absolutely right, bache. Yes. All right. So, yes, it is the lipases. You guys are absolutely right that whenever there is a fasting and starvation like condition, we want our stores to come and give us the energy, right? If the glucagon is not there, then we are going to call for the lipids. And then if it is not sufficient, then we are going to go and move on to the proteins, right? So you guys are absolutely right. We are not going to go for the storage. We are already lacking the energy, right? All right. Then there was some question on the gamma carboxylation. It was okay. There was some question on the gamma carboxylation related to clotting factors. I did not get the exact question. Please help me out to make out the exact questions, right? And the answers was 2, 7, 9, 10. We know that. All right, get it. Babalu saying, why are you crying? So that's all from my side, guys. Optimism is the best way to see the life. Now your exams are over, so don't get stressed, right? Don't get stressed. And my juniors are calling me like, ma'am, just we wanted to talk to you and all these things, that they are getting anxious. Pata nahi ab rank kya aayega. And few days back, they call me and they were getting anxious कि बस ये exam हो जाने दो, then we'll be like having that peace of mind. And now they are worried about the ranks. Why guys, you are doing this, right? Let the results come. You have done your best, right? So today just relax and give this evening some time, right? And watch a movie or have a good night's sleep, right? All right. Fine. So if you permit me, I'll end it with the last share. So yes, guys, I hope you are going to do it just the best. Okay. Right. So I'm going to end this with the share that थोड़ा डूबूंगी मगर, थोड़ा डूबूंगी मगर, फिर तैर आऊंगी, ए जिंदगी तू देख मैं फिर जीत जाऊंगी. I wish you all the best for your ranks, and I would like to give it over to Sir Apu sir.
Thank you for phenomenal words in session, Dr. Pooja. And you know, I will like to close it with a story that goes back to 1987 with the mighty Pakistani bowling attack. 15-year-old Tendulkar debut in Pakistan with scores of 0, 7, and 11 in the 3 matches. And in 2 matches, he was dropped for the 3rd test match, and he had to play the 4th one. You know, and then it was day 5. Indian team were 25 for 5, and he comes to bat. And when he comes to bat, he tries to hook a ball by Waqar Younis, and that hits against his bat and goes and collides at the bridge of his nose, and he bleeds. He falls on the ground, thud, and he bleeds. You know, Navjot Singh Sidhu was standing at the other end, and he saw him falling, and he said, "Call the stretcher." He was rehabilitated, and everybody was trying to take him back. He was wounded, grounded. Indian team had no chance. 25 for 5. Day 5, brutal attack, one of the best in the world. Brutal pitch. Nothing was there, but a feeble voice in between the crowd shouted and said, "Main khelega." Sachin Ramesh Tendulkar made 67 not out in that match. Sidhu made 97 not out in that match. Day 5, the India did not lose. So you never know. Hope floats. It's not over till it is. खुद की काबिलियत पर भरोसा रख. जो गलती आज की है उससे सीख. मत मांग किसी के आगे अपनी सफलता की भीख. तू जलता हुआ रेगिस्तान है. तेरे अंदर कुछ करने की ठान है. तू रुक मत. तुझे करना बहुत कुछ महान है. तू अपने घर वालों की आस है. उनकी उम्मीदों की सांस है. उनको यूं ही नहीं जाया करना है. तुझे अपनी सफलता के लिए अभी बहुत बहुत लड़ना है. I will close this session, and I am just a drop in the ocean of this family called a Cerebellum family. You know, there were teachers throughout discussing all the subjects. Back in the office, mind you, there is the entire team working in every moment to coordinate. And I feel that we as teachers stand on their shoulders and carry the flag. So we are just the face of the entire team working behind stage. And I, on behalf of all of you, the students, all the teachers here, will like to extend thanks. And I think the best voice of Cerebellum, Dr. Sparsh, should close the session. That's all from my side. Thank you very much. Sparsh.
Yeah, I just want to thank each one of our respected faculty members who pitched in at a very short notice and gave their best for this particular recall session. I would like to thank each one of you who had joined at this particular time and you had your faith in us. And for all those people who still have a doubt about Cerebellum, all the naysayers, I would just end up by saying a line. अगर 4 दिन बाज आसमान में ना उड़े, तो आसमान कबूतरों का नहीं होता. And most of you, with your supports, you are our wings. The students are our wings. As teachers, we know that you have given us a power. You have given us as the right kind of support, the blessings, and we'll make sure that we'll do it. We'll win the skies, as they say, for the Indian force. Nabham Sprisham Deeptam. We will rock it. We will do it with utmost glory, and we'll show it to everybody. I do hope all of you are going to be having a very wonderful time. Do spend this quality time with your family members. Cherish this time. You have done your utmost effort with all the ORRs, BTRs, what and what not. Don't worry about the outcome as of now. Just give your mind and your body relaxation that it deserves. So without taking too much of your time, have a wonderful, wonderful evening. All the very best from Team Cerebellum. Thank you so much for your love and faith. We will constantly work harder to make sure that we are going to be absolutely worth all the love that you are blessing on us. Thank you so much again.
Bye, Sparsh. You are the best.
Thank you so much, sir.
We can close the session. Thank you very much.